Berberine is one of the most extensively utilized herbal therapies throughout the world. The traditional use of berberine is in dealing with infection. 25 years ago, a Chinese physician observed that when he used berberine to treat bacterial dysentery in his patients with diabetes, that blood sugar improved. And that led to further investigation as to the hypoglycemic, anti-inflammatory, and lipid-lowering properties of berberine. Berberine is extremely well characterized for those of you who wish to know. It is a quaternary protoberberine type alkaloid with a dibenzo Ag quinazolidine ring. Anyways, it's been very well characterized and its pharmacokinetics are well understood. Berberine activates AMP-sensitive protein kinase. This is the enzyme for primitive man. When primitive man was on a long trek and he was generating reactive oxygen species and he did not have enough energy, he would activate AMP-sensitive protein kinase and it sends a signal, don't build things, burn. I want to burn energy now and make ATP, and I do not want to generate free radicals. So AMP-sensitive protein kinase is upregulated by caloric restriction, energy deficiency, exercise burning off those calories, leptin, adiponectin, metformin, and berberine. Conversely, its expression is downregulated by energy excess and inflammatory cytokines. So our tendency to become a diabetes population, we have energy excess, lots of inflammation, we turn off AMPK with exercise, caloric restriction, therapy with berberine, we upregulate AMPK and we send a signal, burn now, do not build. Thus, benefits of AMPK on lipid control, glucose and weight control. AMPK lowers oxidative stress, inflammation, endothelial function. It provides protection against toxicity and promotes apoptosis of damaged or senescent cells. Let's talk a bit more about the LDL receptor negative feedback mechanism. I'm going to go over this again and again. And this is the Brown and Goldstein model. The level of serum cholesterol relates to the level of expression of the hepatic LDL receptor. If there's a lot of open LDL receptors circulating, LDL will be internalized and catabolized. So we want to lower LDL in the serum. We want high rates of synthesis and expression of the LDL receptor. The liver and every cell of the body will manufacture LDL receptors in relation to its perceived need for free cholesterol. If we have adequate intracellular cholesterol, we'll withdraw the LDL receptor. So in theory, cells should not overfill with cholesterol if they have enough. Now, of course, this mechanism can be bypassed in the presence of inflammation and oxidative stress. But all things being equal, in a non-inflammatory environment, our cells will not overfill with cholesterol. Thus, cholesterol in the diet, in the absence of oxidative inflammatory stress, should not produce significant hyperlipidemia and atherosclerosis, because if our cells have enough LDL, they withdraw their LDL receptor, you will not internalize LDL, and you will not develop excessive levels of free cholesterol within the cell, because we have this negative feedback mechanism. So let's discuss this a little bit more. We have a free cholesterol, a free sterile sensor called INSIG. When there is adequate free cholesterol in the cell, INSIG will sequester SREBP, sterile regulatory element binding protein, and SCAP, sterile regulatory element binding protein, cleavage activated protein, a chaperone of SREBP in the endoplasmic reticulum. When there is insufficient free cholesterol in the cell, INSIG lets go, SREBP and SCAP translocate to the Golgi. SCAP will cleave off some amino acids from SREBP. Now we have the mature SREBP is free to enter the nucleus and bind to the sterile regulatory element, which is the promoter site for transcription of the LDL receptor. So we're going to make LDL receptors. We're going to transcribe messenger RNA for the LDL receptor only if we need cholesterol in the liver. If there's enough cholesterol in the liver, then SREP is sequestered. We stop making LDL receptors. So there's a negative feedback mechanism. If we need cholesterol, we're going to make the LDL receptor. If we have enough cholesterol, we withdraw. We will stop transcribing the LDL receptor. So in therapeutic medicine, we would put our patients on a statin drug. So statins will block the generation of cholesterol within the cell. Okay, there's not enough cholesterol in the cell. INSIG, let's go. SREBP goes to the nucleus, and we're going to start making more LDL receptors. Okay, if we're making more LDL receptors, we're going to pull cholesterol out of the circulation, and then serum cholesterol will fall. That's how statin therapy will work. And of course, it does work. Our cholesterol levels will fall. But 6 months later, they'll rise again. Now, why is that? Well, at first I thought it was because the patients are becoming complacent. You know, they were working on diet didn't work, we put them on a statin, their LDL falls, well then they return to bad eating habits. And sure, that plays a part of it, but in addition, when we lower cholesterol with statins, by blocking HMG reductase, we also sow the seeds for statin resistance, because we have to look at this from the perspective of Mother Nature. Why would primitive man have insufficient cholesterol in his liver? Primitive man wasn't taking statins, but if primitive man was starving, if there was not enough cholesterol in his diet, he would have low intrahepatic cholesterol. So the liver needs cholesterol to make cell membranes, etc. So in response to cholesterol starvation, the liver will transcribe more LDL receptor, so the liver will be pulling cholesterol out of the circulation. In addition, to pulling cholesterol out of the circulation, we're going to make more HMG reductase. So we take a statin and we start making more LDL receptors, but we also start making HMG reductase. So the enzyme that statins inhibit, its transcription is increased in response to intracellular hyperlipidemia from statin therapy. Furthermore, Mother Nature didn't create this mechanism solely to make sure the liver has enough cholesterol. If the liver is going to make LDL receptors and pull all the cholesterol out of the circulation, it will be stealing from the rest of the body. The rest of the body, particularly the brain and our endocrine organs, need cholesterol. So when we make LDL receptors and HMG reductase, we're also going to make PCSK9, which is another horrible name, proprotein convertase subtilisin kexin type 9. Now what PCSK9 does, it degrades the LDL receptor, blunts return of the LDL to the river, raises circulating LDL, so it's kind of a balancing act. So Mother Nature is going to make LDL receptors, but to avoid the liver from hoarding all the cholesterol, the liver will also make PCSK9 to degrade the LDL receptor to provide a balance. Now, the expression of PCSK9 is increased with inflammation and infection, inflammatory cytokines. So one of the reasons we have hyperlipidemia with age is because we become diabetes, we're inflamed, we have inflammatory cytokines, we make a lot of PCSK9, that degrades the LDL receptor, the liver is no longer able to pull LDL out of the circulation, we have hyperlipidemia. And we take a statin, yes, we will lower intracellular cholesterol, we will make more LDL receptors, but we'll also make more HMG reductase to make more LDL, and we will make more PCSK9 to degrade the LDL receptor. So statins have a role, but whenever we meddle with Mother Nature with the drug, there's always a downside, and the downside is increased expression of HMG reductase and increased expression of PCSK9. Now, we now have the PCSK9 inhibitors. Subcutaneous injection of a monoclonal antibody to inhibit PCSK9 will lead to profound reductions in LDL cholesterol. PCSK9 degrades the LDL receptor, blunts return of LDL to the liver, raises circulating LDL. We can neutralize PCSK9 and LDL falls. So we have these patients on high-dose statin therapy, and they have residual hyperlipidemia, mainly because they're making PCSK9. If we knock out PCSK9, LDL will fall dramatically. And we all have patients who are refractory to statin therapy. They're having side effects. They can't take statins. They're having recurrent cardiovascular disease. These PCSK9 inhibitors work very, very well, and they've been a godsend for many of my patients. Most of my patients with recurrent heart disease, we do everything we can, but some of the patients we cannot lower their cholesterol. So we're not getting the job done. We use the PCSK9 inhibitors, and they work. Now, you can use a PCSK9 inhibitor without concomitant HMG reductase inhibition, and they will work. But they work a lot better if you have something on board to inhibit HMG reductase. So you have a patient who has hyperlipidemia on 80 milligrams of atorvastatin. They're having side effects, but their cholesterol is high. You add in the PCSK9 inhibitor. You can cut that atorvastatin down to 10 to 20 milligrams. You'll still get a synergy. You'll get the desired result. And these agents do not appear to be causing any important side effects. There are individuals who are genetically do not make PCSK9. They go through life with an LDL of 40. and they enjoy good health. So we don't have to have PCSK9. One of the causes of familial hyperlipidemia is excess expression of PCSK9. So knocking out PCSK9 pharmaceutically is not associated at this point with ill effects. Now, I have had a small number of patients that stopped this therapy. They had aches and pains, probably because we got their LDL down to the point where other organs were starving. We all understand that phenomenon. And one man who did not have coronary disease but hyperlipidemia, we put him on a PCSK9 inhibitor. He developed an unusual side effect, a craving for cream. He'd be at work driving down the road. He'd see a 7-Eleven. He would feel compelled to stop and get some cream and drink it to make him feel better. So we figured out maybe we kind of overdid it. So we did stop the PCSK9 inhibitor in him. But as a general rule, there are no serious side effects of this approach. The downside is it's incredibly expensive. To get insurance pre-authorization involves a painful amount of paperwork. It's very difficult to do, but when you do get pre-authorization, the patient goes on it, it can make a big difference. So PCSK9 is our antibody, is our enemy, and we can use these monoclonal antibodies to neutralize PCSK9, providing a hypolipidemia effect. And as we're going to see, berberine will work by directly blocking the transcription of PCSK9, providing this therapy for us, although in a qualitatively similar but quantitatively less powerful effect. Berberine blocks transcription of PCSK9. It enters the nucleus, it sits on the promoter, so berberine selectively inhibits PCSK9 transcription, explaining some of the lipid-lowering benefits of berberine. So what is the effect of berberine on hepatic cholesterol metabolism? So we take a statin, we go on a low cholesterol diet, and we're going to lower the amount of free cholesterol within the hepatocyte. SREBP translocates to the nucleus, and we start transcribing messenger RNA for the LDL receptor. But that messenger RNA must be translated into protein in the cytoplasm. The messenger RNA can be degraded. Berberine stabilizes the messenger RNA. So for any degree of upregulation of transcription of messenger RNA for the LDL receptor that is achieved with statin therapy or any other lipid-lowering methodology, it will be amplified by berberine because more of that messenger RNA will be translated into LDL receptor protein. Berberine does not inhibit directly HMCO reductase like a statin drug does, but by upregulating AMP-sensitive protein kinase, we will physiologically downregulate HMCO reductase. I'll talk about that a little bit more, and it blocks transcription of PCSK9. So berberine will independently lower lipids, and it synergizes nicely with statins or non-statin HMCO reductase inhibitors. And berberine upregulates AMP-sensitive protein kinase, which sends a burn things now, do not build. I want ATP energy now, and I want to decrease the generation of free radical mediators. So berberine tricks the body into thinking that there's energy failure. So we have a transient increase in the ratio of AMP to ATP, suggesting we have energy failure, and that upregulates phosphorylation of AMP-sensitive protein kinase. When we phosphorylate it, we activate it. Phosphorylated or active AMP-sensitive protein kinase will phosphorylate and thus deactivate HMCO reductase. So we have the HMCO reductase protein, we inactivate it with berberine via upregulation of AMPK. So we're going to physiologically downregulate HMCO reductase, decrease cholesterol biosynthesis. LDL receptor expression is increased because we blunt degradation of the messenger RNA. More LDL receptor messenger RNA is translated. We blunt transcription of PCSK9, decrease in serum LDL. We also phosphorylate ACC carboxylase. This will decrease fatty acid synthesis and increase fatty acid oxidation. We're going to burn fatty acids for energy to recycle ADP into ATP, lower triglycerides. Berberine will directly increase the expression of insulin receptors. It will blunt inflammatory hyperglycemia. It blunts serine phosphorylation of the insulin receptor substrate, so it improves insulin sensitivity, it blunts inflammation-induced insulin insensitivity, it will lower blood sugar, and it's been shown in animal models to be protective against nephropathy, retinopathy, neuropathy, and cardiomyopathy in diabetic animals. It's helpful with weight. With respect to oxidative inflammatory stress, berberine, like colchicine, blunts assembly of NADPH oxidase, Superoxide production is decreased. Nuclear factor kappa beta inactivator protein 1 translocation is blunted, while NRF2, which codes for antox and detox molecules, translocation is enhanced. Endothelial function improves. Many effects in animal models on various aspects of cardiovascular biology. Many clinical effects in italics are animal models. In standard print are human studies. Berberine improves outcome. Following PCI for ACS, it's useful in heart failure. I'll show you those studies. Berberine synergizes with and adds to standard pharmaceutical measures. On my website, there's a 9-hour presentation, The Chronicles of Berberine, that goes over all these clinical trials. And of course, you and your patients are welcome to look at all that. Let's look at the effect of berberine for lipid control in the elderly. 80 elderly non-diabetic hyperlipidemic subjects with statin intolerance or they refuse to take statin therapy. Most patients who I see just don't want to take statins. Some really can't take statins, but most of them just really don't want to. And I understand that. I wouldn't want to take a drug either. I will recommend statins if I think they really need it, but of course, we would rather use a nutraceutical approach to lipid reduction than relying on pharmaceutical statins. So anyways, they're above 75 years of age. Cholesterol is above 200, LDL is above 160, 60% were hypertensive, 25% were smokers, and this was secondary prevention, 84%, 45 had coronary disease, 33 had peripheral vascular disease. You do the baseline measurements, randomize them to receive red yeast rice extract, 200 milligrams a day, and polycosanol, 10 milligrams a day. Both of these will inhibit HMG reductase. These are fairly low doses. Polycosanol seems to work very well in the Cuban literature. It does not seem to work well in Europe or the United States. The standard dose of red yeast rice would be 1,200 to 3,600 milligrams a day. So this was a fairly low dose of an HMG reductase inhibitor, and they received berberine, 500 milligrams a day, and some coenzyme Q and folate and the antioxidant astaxanthin. So this cocktail of beneficial substances, primarily berberine or placebo, repeat the baseline measurements over 12 months. Cholesterol was unaffected with placebo therapy. It falls from 252 to 201 with the nutritional cocktail. LDL drops from 170 to 119. Now, if we used a statin and we got that result, we'd say, hey, yeah, the statin worked pretty well. This non-statin approach that involved low-level HMG reductase inhibition with the red yeast rice and the berberine, and with the red yeast rice and polycosanol and the berberine to physiologically downregulate HMG reductase, stabilize the messenger RNA of the LDL receptor, and block PCSK9, we get a wonderful synergistic effect. HDL rose in both groups. Typically with statin therapy, HDL does not rise. It did rise with this approach, and triglycerides fell. Fasting glucose fell because there's an increased expression of the insulin receptor. Hemoglobin A1C fell from 5.7 to 5.3. Now, we use statins. We all understand now that statins lead to an element of insulin insensitivity. Sugar rises, insulin rises. That's clearly deleterious. That does not happen with this methodology because berberine directly improves insulin sensitivity. HOMA, which is a calculation to describe insulin resistance, improved with the nutritional cocktail. Degree of clinical improvement, cholesterol fell by 20%, LDL by 31%, HDL rose by 10%, triglycerides dropped by 10%, HOMA dropped by 10%. No change in liver chemistry or CPK values. Mild side effects, 10% the treatment group versus 18% the placebo group, so it wasn't associated with an increased risk of a side effect. No events or mortality in either group. It was safe and effective in elderly subjects with hyperlipidemia, risk factors, or cardiovascular disease with no. Let's now look at the therapeutic utility of berberine in patients with metabolic syndrome. 37 adults with newly diagnosed metabolic syndrome. Baseline measurements, you treat them all with berberine, 300 milligrams 3 times a day. Repeat the measurements at 12 weeks. You're going to look for nuisance side effects or any safety issues. Nuisance GI side effects in 5%, resolved with a dose decrease to 200 milligrams 3 times a day. In my experience, 5 to 10% of individuals who experience constipation or diarrhea with berberine, it's dose related. You cut the dose in half and these symptoms will resolve. No adverse effect on liver or kidney chemistries. The side effects of berberine are nuisance side effects, not serious side effects. There's no damage to our organ system. Lipids. Cholesterol fell. LDL fell from 142 to 110. HDL fell slightly, but the percentage of total cholesterol made up by HDL did not fall. Triglycerides fell, fasting sugar fell from 130 to 110. Now we can lower cholesterol with a statin and lead to insulin insensitivity. We can lower cholesterol with berberine and improve insulin sensitivity. Insulin levels fall. HOMA, a calculated measure of insulin resistance, decreases. Leptin falls, adiponectin rises, just what we want to see. Blood pressure falls slightly with berberine. Body mass index and waist circumference fall. Berberine activates AMP-sensitive protein kinase that sends a signal: burn sugar and fat for energy, don't store, don't convert sugar into triglycerides and fat. Thus, body mass index, waist circumference falls. Blood pressure falls slightly. Lipids fall a lot. Insulin sensitivity improves a lot with berberine. How about berberine in type 2 diabetes? If it works in metabolic syndrome, it's going to work in full-fledged type 2 diabetes. 110 adults with newly diagnosed and not yet treated diabetes, sugar above 125, or their 2-hour post-glucose load sugar was above 200. They were hyperlipidemic, high cholesterol, etc. Advised all on diet and exercise, baseline measures, randomized to a 12-week program of berberine, 500 mg twice daily, placebo twice a day. Repeat the measurements at 12 weeks, double-blind protocol was followed. Weight falls a little bit in both groups. It falls more with the berberine group. That was not a big difference. Body mass index falls a little bit with both groups. There was no statistically significant benefit here of berberine. Blood pressure falls slightly with placebo therapy. It falls a little bit more with berberine, not a prominent, but still a positive effect of berberine supplementation. Glucose falls a lot more with the berberine group than with placebo therapy. It falls 15 points. That was statistically significant. 2-hour post-glucose load sugar falls with placebo therapy, but it falls a lot more with berberine. Fasting insulin falls. 2-hour insulin falls. So insulin sensitivity improves. Sugar falls. The pancreas no longer has to release as much insulin because insulin sensitivity is improving. Lipid values improve. There's very little effect of placebo therapy on lipids. Total cholesterol falls from 205 to 168, LDL from 125 to 98. Triglycerides falls a little bit with placebo, a little bit more with berberine. IL-6 falls with both therapies. The trough level is lower with berberine. Liver function tends to improve with berberine. Berberine is of value in fatty liver. It's lowering inflammation. Therefore, you're going to have a reduction in transaminases. Another study of berberine in type 2 diabetes, 97 adult subjects with type 2 diabetes, fasting sugar above 125, post-meal glucose above 199. Stop prior treatments for 2 weeks pre-study, baseline measurements. You're going to randomize them to receive over 8 weeks berberine at a standard dose of 500 milligrams twice a day, metformin, which like berberine upregulates AMP-sensitive protein kinase, a standard dose of 750 milligrams twice a day, and rosiglitazone, 4 milligrams daily. That's a thiazolidinedione. They increase insulin sensitivity more at the level of the muscle. Metformin is working more at the level of the liver. So we're going to be comparing berberine to 2 different insulin sensitizers. Repeat the measurements at 8 weeks. Fasting glucose falls to the same degree with all 3 therapies. A1C falls the same, triglycerides fall the same. So in this head-to-head comparison, berberine works as well as metformin and the thiazolidinedione. Liver chemistries fell with berberine. They don't fall with the other therapies. Liver chemistries improve within the normal range. Kidney chemistries are stable. No adverse effects with berberine treatment. Berberine in post-PCI inflammation. 181 subjects with successful PCI, balloon angioplasty or stent to address an acute coronary syndrome. All received standard therapy, dual antiplatelet therapy with aspirin and clopidogrel. They all received 20 milligrams of atorvastatin, which will downregulate NADPH oxidase, lowering oxidative stress, lowering nuclear factor kappa beta translocation. Concomitant therapy, a third were getting an ACE inhibitor in arm, 95% a beta blocker, and 70% were being treated for insulin insensitivity with a hypoglycemic agent. Baseline measurements on post-PCI day 1, then randomized to receive over 30 days standard therapy or standard therapy, dual antiplatelet therapy, and atorvastatin plus berberine, 400 milligrams 3 times a day. Repeat the baseline measurements at 30 days. Cholesterol falls and LDL falls to the same degree in both groups. They're all getting atorvastatin. Triglycerides falls a little bit more with berberine. Fasting sugar pretty much unchanged in both groups. C-reactive protein falls in both groups. The farther you get away from the acute event, the less inflammation. It falls a little bit more with berberine. IL-6, though, rises in the control group, and it falls significantly with berberine. Monocyte chemotaxic protein is released by the endothelial cells and brings monocytes in. VCAM and ICAM are adhesion molecules to facilitate translocation of the monocytes from the circulation into the subendothelial space. So MCP1, VCAM1, ICAM1 falls. So you're having this acute beneficial effect on endothelial function. You're inhibiting translocation of monocytes to become macrophages within the intima. Matrix metalloproteinase, which degrades the fibrous plaque, falls with berberine. Tolerance and safety, no adverse effects on renal or hepatic chemistries. 3 of the 68 experienced nuisance GI side effects and stopped berberine. They could have decreased the dose, and then they could have continued with berberine at a lower dose. Adverse event rate falls from 10% to 6.6% when you add in berberine. If berberine was a patentable drug, we would be seeing television ads during the Super Bowl. It is not a patentable drug, so American physicians will not be made aware of the benefits of adding berberine to standard therapy following PCI. We're all for PCI. We're all for bypass surgery. We're all for the use of drugs, but if we can complement drugs with low-cost nutraceuticals that will neutralize some of the negative effects of the drugs and provide independent anti-inflammatory and antioxidant effects to get the best outcome, that is what we are for. Berberine in congestive heart failure. This study was done in China where berberine is a standard therapy. 156 patients with chronic advanced heart failure. Their mean ejection fraction is 22%. They were all experiencing arrhythmia, a greater than 90 PVCs per hour or non-sustained runs of VT on the Holter. 60% ischemic, 40% non-ischemic dilated cardiomyopathy, all on a stable medical regimen. Standard medical therapy is tolerated. Baseline measurements randomized to receive placebo with standard therapy or add to standard therapy berberine 300 to 500 milligrams 4 times a day. You start at 300 milligrams 4 times a day, and you can do blood levels in China, and the target level would be a level of 1. So they would increase the berberine dose to get the proper level. Repeat baseline measurements at 8 weeks, periodic reassessment over 2 years. New York Heart Association functional class improved over time in both groups, as it typically does. There's always a benefit of being in the placebo group. It falls a little bit more, so there was a greater degree of symptom attenuation with berberine. 6-minute walking distance increases in both groups. It increases more with berberine. Ejection fraction rises 5 points with placebo. It rises 10 points with berberine. So systolic function improved with berberine. Why? You're lowering inflammatory and oxidative stress. There's an antiarrhythmic effect. The frequency of PVCs over 24 hours fell with placebo. It fell dramatically with berberine. Runs of non-sustained VTAC on the Holter falls with placebo. It's all but resolved with berberine. So pump function improves and arrhythmia frequency and complexity falls. Event rate, mortality, 16% with placebo, 9% with berberine. Hospitalization, 36% with placebo, 20% with berberine. These are the different components of the event rate. So there was an improvement in pump function. There was an improvement in symptoms. There was a decrease in arrhythmia, lower mortality, lower degree of hospitalization. So if we add berberine to standard medical therapy in our patient with heart failure, we would expect improved functional status and improved outcome. And indeed, that is the case. Clinical use of berberine. For lipid management, I start at 500 milligrams twice a day. I advance to 3 times a day if the results are suboptimal or if the patient is receiving high-dose statin therapy. We'll discuss this a little bit later in the presentation, but the greater the dose of statin, the greater the relative need of berberine. So I might go to 1,000 milligrams twice a day. I'll be limited not by real toxicity, but by constipation and diarrhea. As we'll discuss, there's a profound synergy between berberine and statins, red yeast rice extract, polycosanol, ezetimibe, or diet. Because if we lower the hepatic cholesterol level, we're going to transcribe messenger RNA for the receptor, and berberine will stabilize that messenger RNA. If we lower cholesterol generation in the liver with diet or drugs or any other methodology, we're going to make not just LDL receptors, we're going to make PCSK9, berberine blunts that. Typically, if I add berberine to statin therapy, I can decrease the statin dose by 50%. So the patient's having myalgia, they're having cognitive decline at, say, atorvastatin 40 milligrams, I can cut it to 20 milligrams, I add in berberine, I get an equivalent lipid-lowering effect, I get a superior effect on inflammation, oxidative stress, and insulin sensitivity, and because I decrease the statin dose, side effects are attenuated. For glucose management, I start at 500 milligrams twice a day, I go to TID if results suboptimal, and berberine is equivalent to thiazolidinedione and metformin, and other studies that I did not present show that there's a synergy. For inflammation or to protect against toxicity, I start at 500 milligrams twice a day. I advance to 3 times a day if I still see a great deal of inflammation. In cardiovascular disease, I start at 500 milligrams twice a day. I advance to 3 times a day if results suboptimal, up to 2,000 milligrams a day in heart failure. What are the downsides? 5 to 10% of people get constipation or diarrhea, and then you decrease the dose. There's a rare patient who's totally intolerant to berberine. Now, if the patient is on insulin and sulfonylureas and susceptible to hypoglycemia, and you add in berberine and improve insulin sensitivity, you could get hypoglycemia. Berberine monotherapy will not cause hypoglycemia, but it will make the insulin, the sulfonylurea therapy more effective, so you have to be watchful for that. There's a single case report of an adverse effect of berberine in the world literature. This was a physically active man with a tendency to bradycardia. His heart rate was 50. He went on berberine. He developed pathologic bradycardia. They were thinking about putting in a pacemaker, but he's in the hospital. He's not getting his berberine. His heart rate goes up. They put him back on berberine. His heart rate falls. That is the only side effect that's been reported in the literature. So berberine is exquisitely sensitive. Later on, I'll present studies talking more about statin-berberine synergy. So berberine is effective in heart failure. What other nutraceutical approaches are available to improve the functional status and outcome of our patients with congestive heart failure? Let's consider bioenergetic support for the tired and energy-starved heart. Please consider the heart, a section of the heart, or a myocyte. What is the effect on physiology when the myocytes are overworked? Say there's myocyte loss due to a prior infarction. The remaining myocytes have to work double time to pick up the slack, or when the heart is straining to eject blood across a narrowing aortic valve. We have this overwork situation. Or when the myocytes are being whipped by catecholamines, cytokines, and other inflammatory mediators, or if oxygen delivery is insufficient due to the presence of coronary disease. How would these strains compromise myocardial metabolism? How would these stresses affect ATP recycling and cardiac function? How can we analyze this situation and what can we do about it? Well, modern day therapy for heart failure will involve neuroendocrine blockade. Irrespective of the cause of heart failure will be characterized by impaired forward pump function. Delivery of oxygenated blood to the periphery will be compromised, and the body will cry foul. The autonomic nervous system, the kidneys, and the adrenals will respond to this hypoperfusion by releasing mediators that will whip the heart, so the heart will provide them greater service. Consider the situation of primitive man. Primitive man did not have heart attacks. Primitive man did not have cardiomyopathy. Why would there be hypoperfusion in the situation of primitive man? This would involve hypovolemia, hemorrhage, or infection. Those would be the situations in which delivery of oxygenated blood to the periphery will be compromised. So our body responds as if we are hypovolemic or hemorrhaging or experiencing infection. So what will happen is the kidneys will release renin, and this will lead to an outpouring of angiotensin II, a vasoconstrictor. That makes sense because if you're hypotensive, you want to have vasoconstriction. The adrenals will then release aldosterone to retain sodium and water to expand your vascular blood volume. Catecholamines will be elaborated to whip the heart into greater action, greater contractility, and additional vasoconstriction. So these phenomenon, while adaptive in the situation of volume depletion, infection, or hemorrhage, are maladaptive when heart failure is due to myocyte loss or myocyte strain. So this response of the endocrine system and the autonomic nervous system will be damaging to the heart. So therefore, irrespective of the cause of heart failure, we can apply neuroendocrine blockade, and this certainly works well. When I was in medical school, the 1-year mortality for severe heart failure was 50%. All we had was digoxin and diuretics, and that's what we used. And we did pay attention to potassium. Nobody was talking about magnesium. We were creating a great deal of electrolyte and B vitamin deficiency. Patients obviously didn't do very well. If you have a patient on digoxin and we render them hypokalemic, they'll experience digitalis toxicity and die of sudden death. And the 1-year mortality for heart failure was 52%. ACE inhibitors came out when I was a resident, and we had a new approach to deal with heart failure, neuroendocrine blockade. We could block the generation of angiotensin II. We could block the vasoconstriction. Thus, we were reducing afterload, lowering oxidative stress, although at the time we didn't really understand what oxidative stress was. Anyways, the annual mortality fell to 36%. Then spironolactone became utilized in the treatment of heart failure. It was a weak antihypertensive agent before then. Then we learned that it was helpful to block the deleterious effects of aldosterone. Now, aldosterone, of course, it's going to retain sodium and water, but it also causes strain on the myocyte. It leads to diastolic dysfunction. It leads to myocardial fibrosis. So adding in spironolactone, mortality falls further. Well, we've got the autonomic nervous system whipping the heart. Agonism of the adrenergic receptor in the myocyte leads to fetal contractility and cell loss apoptosis. So if we block this with beta blockers, 1-year mortality improves to about 12%. So before neuroendocrine blockade, the 1-year mortality is 52%. Now the 1-year mortality is 12%. Of course, can we add on this with nutraceutical approaches? Of course we can. So when we approach the patient with heart failure, irrespective of the cause, there's neuroendocrine blockade. As we'll discuss, these strained myocytes are struggling to generate ATP. Cofactors involved in ATP generation will be depleted, and if we supply those, such as coenzyme Q and magnesium and ribose to support the generation of adenine nucleotides and carnitine, we will improve myocardial bioenergetics, and that will improve outcome. Oxidative inflammatory stress occur when you have this catecholamine outpouring. You're going to get oxidative inflammatory stress. Also, in the situation of heart failure, there's going to be translocation of bacterial lipopolysaccharide into the circulation, and there is actually a septic component to heart failure, and we're going to get an immune response. In addition, when the heart is being stressed and strained, abnormal myocardial antigenic determinants will be elaborated, and there will be a T-cell-led Th1, Th17 skewed immune response against the myocytes. So there's always going to be an immune component in heart failure. In addition, some of the newer methodologies, if you have left bundle branch block, you're going to have dysynchronous contraction. Dual chamber pacing makes sense. You're vulnerable to arrhythmias, of course, and this is where defibrillator placement comes into play. And then we're going to be talking in this section about bioenergetic support with coenzyme Q and carnitine, etc., to help us generate more ATP so the myocyte can keep up with the strain that is imposed upon it. Let's also consider an integrative approach to ischemia. So you have the patient on the treadmill, they experience pain at a certain level, and we see ST segment depression. So what's the cause of ST segment depression? You know, and I'm going to ask you, if I was giving this talk live, one of you might say, well, ST segment depression occurs because of impaired blood flow. Another person might say, well, it reflects oxygen deficiency at the level of the myocyte. Actually, ST segment depression reflects angina, and ST depression on the treadmill reflect not just oxygen deficiency, but rather ATP deficiency. we require a high content of myocyte ATP to drive forward all useful chemical reactions in the heart, to drive forward all useful chemical reactions in the body. Systolic dysfunction and angina reflects an extreme reduction in myocyte ATP. But before that occurs, we're going to have diastolic dysfunction and derangement in other myocardial metabolic activities. So we want a high content of ATP. We don't want to wait to intervene until we have angiopathy second depression. We want to maintain a high content of ATP within the myocardium, because as ATP falls, one by one, cellular functional mechanisms become depressed. So what are the materials that we need to generate ATP, to recycle ADP back to ATP? Of course, we need oxygen for oxidative phosphorylation. We need coenzyme Q, we need carnitine, we need magnesium, and we're going to buffer our magnesium supplies with taurine. We need adenine nucleotides to rephosphorylate, and here we can intervene with ribose. So let's start with coenzyme Q. We're all familiar with the benefits of coenzyme Q. Coenzyme Q stabilizes cell membranes, blocks deleterious effects of phospholipases. You could consider CoQ as our primary metabolic antioxidant. It is a direct free radical scavenger. It will upregulate the expression of extracellular endothelial superoxide dismutase, and it will inactivate superoxide. Coenzyme Q will regenerate spent or oxidized vitamin E, and it's key in mitochondrial electron transport. Without coenzyme Q, you cannot transport electrons. You cannot generate energy within the myocyte or with any cell in the body. Coenzyme Q is thus critical for life. Now, CoQ levels in the blood and within the myocyte will fall in the situation of congestive heart failure. Blood levels reflect myocardial levels because the heart is the greatest utilizer of coenzyme Q in the body. So if you go from normal individuals or mild class 1 heart failure to class 2 to class 3 or 4, you'll see a decrement in blood and myocardial coenzyme Q. The same thing in coronary patients who are experiencing oxygen deficiency. CoQ levels are lower. CoQ travels in the LDL, it's lipophilic, and the ratio of LDL to coenzyme Q will be greater in coronary patients than in healthy controls because they're suffering from coenzyme Q depletion due to oxidative stress and metabolic derangement concomitant with coronary insufficiency. Now, this slide is about 10 to 15 years old, and this lists the studies, randomized double-blind studies, and some open interventions demonstrating benefits of coenzyme Q in cardiovascular disease. So when the American College of Cardiology says there's no studies to support nutritional intervention, again, another statement that does not have a basis in reality. Coenzyme Q is helpful in coronary disease, angina frequency and severity treadmill time, post-MI outcome, post-bypass outcome, value in heart failure and cardiomyopathy. CoQ improves endothelial function, will lower blood pressure, improves insulin sensitivity, lipids, blood pressure, and LPA in patients who had experienced an ACS. Coenzyme Q is helpful in end-stage renal disease, migraine, Parkinson's disease, and in statin myopathy. And there were some open studies showing benefits in other cardiac conditions. Basically, no one's ever done a study that shows that coenzyme Q does anything bad. And every study where it's been looked at intelligently and care has been taken to provide an adequate dose of coenzyme Q, they all show benefits on outcome, and we'll review a few of these. Let's look at coenzyme Q and endothelial function in heart failure. Poor endothelial function has an adverse effect on prognosis in patients with heart failure, and it's associated with impaired functional status. If we can improve endothelial function, we should improve functional status, and we should improve outcome in our patients with heart failure. So, will coenzyme Q help? 23 patients with significant heart failure. They all had ischemic cardiomyopathies, 60% with prior revascularization, mean ejection fraction 37%. They've been stable for 3 months, and they're all on optimal standard medical therapy, 2/3 on beta blockers, 2/3 on ACE inhibitors, 1/3 on an ARB. Baseline studies randomized to receive over 4 weeks placebo and exercise training, 5 sessions a week at 60% peak oxygen uptake, CoQ 100 milligrams 3 times a day, or combination therapy, exercise training 5 sessions a week, and CoQ 100 milligrams TID. Restudy at 4 weeks, then cross over to the other regimen. Double-blind, placebo-controlled crossover protocol was followed. So what you see, coenzyme Q levels rise from 0.8 to 3.6. Brachial artery flow-mediated vasodilatation, a marker of endothelial function. Endothelial function is impaired in heart failure due to primarily oxidative inflammatory stress. The intimal environment is oxidative, not reductive. Nitric oxide synthase is generating superoxide and not nitric oxide. So exercise training improves. Well, again, increased laminar flow upregulates nitric oxide synthase, upregulates NERV2, upregulates AMP-sensitive protein kinase. We're going to start making more nitric oxide, endothelial function improves. Coenzyme Q works as well. Coenzyme Q not only improves myocardial performance, it lowers intimal oxidative stress. Therefore, nitric oxide synthase will start making nitric oxide as opposed to superoxide. And of course, there's a synergy between exercise training and coenzyme Q. So if we want to take an integrative approach to our patients with heart failure, yep, an exercise program makes sense. Regular exercise makes sense. Coenzyme Q makes sense. Putting them together, we get a synergistic improvement in endothelial function. And if you have peripheral endothelial dysfunction, you're going to have what I'm going to call central endothelial dysfunction. The myocyte will have a low ratio of nitric oxide to superoxide, and that will directly impair contractility. So we want great endothelial function in our patient with heart failure, not just to have like afterload reduction with peripheral vasodilatation. We want there to be enough nitric oxide within the myocyte to optimize myocardial contractility, and we can achieve this with exercise or with CoQ or with combination therapy. Now, peak oxygen uptake is our most important measurement of mitochondrial fitness, and it rises with exercise training, it rises with CoQ, and there's a synergy between exercise training and CoQ. Resting ejection fraction rises a few points with exercise training and CoQ, and there's a synergy with combination therapy. Peak ejection fraction during dobutamine stress also rises, and again we see the synergy. They divided the subjects into peak on treatment CoQ levels below 2.4 or above 2.4, and you had a better incremental increase in flow-mediated vasodilatation. And systolic wall thickening score, you want a low score. A high score reflects ischemia. It fell more. So they found that if they don't get the CoQ level up to 2.5, patients don't get the maximum benefit. If you get above 2.4, you get a greater benefit. Therefore, dosing is important. The worse the heart failure, the lower will be circulating and myocardial coenzyme Q. Thus, the greater the dose that would be required to rectify this pathophysiology. That makes sense. CoQ and endothelial function in coronary disease. We've shown that CoQ helps along with exercise training in improving endothelial function in heart failure. What about coronary disease? 38 patients with stable coronary disease. They're on medical therapy. 58% smokers, 18% diabetic. The patients we would see in our office, they're on standard drug therapy, baseline measures, randomized to receive over a month, CoQ, 300 milligrams a day, placebo, restudy at 4 weeks, double-blind protocol followed. You could give they gave the CoQ 100 TID, but CoQ's fat soluble. You can give it as a single dose once a day if you wish to. Here they did it 100 milligrams 3 times a day. So CoQ levels rise. We get up above 2.5. Vascular wall extracellular superoxide dismutase increases. Now we're not supplying superoxide dismutase, but coenzyme Q, functioning as an antioxidant, is squelching superoxide. Thus, there's less strain on the SOD system, so superoxide dismutase levels are higher. Flow-mediated vasodilatation improves, and mitochondrial fitness, VO2 max, improves with coenzyme Q. Same as the patients with heart failure. Now, the greater the rise, the percentage increase in coenzyme Q, the greater was the percentage increase in flow-mediated vasodilatation and the increase in superoxide dismutase activity. So the lower the CoQ level, the worse the endothelial function, the greater the oxidative stress, the greater will be the relative benefit to the patient with coenzyme Q supplementation. That makes sense. The greater the upside potential, the greater the response to coenzyme Q. In the trial to assess chelation therapy, the diabetics experienced the greatest improvement in outcome with CoQ and antioxidant supplementation because at baseline they were suffering the greatest degree of oxidative stress. Same situation here in these patients with coronary disease. The greater the degree of oxidative stress, the worse was endothelial function, the lower was superoxide dismutase availability. If we give CoQ and we lower oxidative stress, we'll get relatively greater increases in antioxidant function and in endothelial function, and redox status go hand in hand. Individuals with above median baseline superoxide dismutase, their superoxide dismutase level did increase with coenzyme Q from 23 to 27, but their relative increase in superoxide dismutase was less than that of those with lower baseline SOD levels. So the lower the baseline SOD, the more oxidative stress, the greater the relative need for CoQ, the greater the relative benefit of CoQ with respect to lowering oxidative stress such that you can maintain superoxide dismutase levels. And if they would have looked at catalase or glutathione peroxidase, they would have seen the same thing. Same with flow-mediated vasodilatation. Those with above baseline SOD levels had better residual endothelial function than those with below average baseline. Both groups will improve, but you get a relatively greater improvement the lower the baseline level of superoxide dismutase as you would expect. Coenzyme Q and effort tolerance. How will these biochemical changes be translated into functional status improvements? 12 patients stable effort-induced angina, all had a coronary narrowing. 5 of the 12 with a prior infarction baseline study. Randomized them to CoQ 50 milligrams 3 times their placebo. Repeat the baseline studies. Then you cross over to the opposite group and restudy. So coenzyme Q levels don't rise with placebo. We really want to have a CoQ level about 2.5 in our patients. If you do lab studies, there'll be normal population levels, but if you have heart failure or coronary disease, you have a relatively increased need for CoQ, perhaps to make up for depletion of other cofactors or the overwork situation of the heart in heart failure or the metabolic derangements of hypoxemia if you have coronary disease. So you really want to have a level of 2.5. And of course, they were low at baseline. With CoQ supplementation, they got up to 2.2. Symptomatic status, angina worsened with placebo. It fell with coenzyme Q. Nitroglycerin requirement fell with coenzyme Q, as you would expect, because you're improving endothelial function and you're improving the efficiency of ADP to ATP recycling. Treadmill time, time to ST segment depression was unchanged with placebo. Treadmill time and time to ST segment depression was enhanced with coenzyme Q because you're not opening up the artery, but you're improving the ability of the myocytes to utilize oxygen to recycle ADP to ATP. And if you can prolong the time period before you run out of ATP, you're going to have less angina, less ST segment depression, and increased treadmill time. And the change in treadmill time, the improvement in treadmill time correlated with the relative increase in coenzyme Q. So the lower the CoQ, the lower your treadmill time, the greater the degree of positive response to coenzyme Q supplementation. CoQ plus selenium and post-MI outcome. Again, it's kind of dumb to treat our patients with one molecule when we understand that heart failure and infarction and ischemia lead to deficiencies in multiple myocardials critical in our antioxidant defenses and in ADP to ATP recycling. So here they took 61 patients with acute MI, all get standard medical therapy, randomized to placebo or a cocktail, 500 mics of selenium and CoQ 100 milligrams within the first 6 hours, then daily therapy with selenium and some trace minerals and some zinc, and CoQ 100 milligrams a day for a year. Follow-up over 1 year, double-blind protocol follow. QT interval decreased in the treatment group. This was a European study, so they called the treatment group the Verum group. QT interval increased with control therapy. So that's a sign of electrical instability that was corrected, at least in part, with the nutritional cocktail. Now, of more importance to us is 1-year mortality in the placebo group was 21%, all from repeat infarction. In the treatment group, 1 in 32 subjects died from a pulmonary embolism following motor vehicle accident. Kind of an accident there, not due to heart failure or recurrent coronary disease. While the placebo group had a 21% reinfarction rate, the coenzyme Q and selenium group obviously enjoyed a better outcome. If you go to the literature, you'll find hundreds, if not thousands, of studies, randomized double-blind studies that demonstrate a benefit of coenzyme Q in essentially all cardiovascular disease syndromes. Yet, American cardiologists have not adopted coenzyme Q supplementation within their therapeutic armamentarium. And despite this overwhelming positive literature, the objection has been, well, the studies aren't large enough, therefore they're not significant. And I think that's kind of an arrogant position that one would take when they simply don't want to recognize that a non-drug approach would be helpful. But anyways, to address this concern, the Q-SYMBIO trial was conceived and executed. So in Co-SYMBIO, they took 420 subjects with class 3 or class 4 heart failure. So you're having symptoms at mild activity or at rest, enrolled from 17 centers throughout the world. 70% of the patients suffered from ischemic cardiomyopathy, 27% with a non-ischemic dilated cardiomyopathy, 3 had end-stage valvular disease. Mean ejection fraction 31%. Their pro-BNP was 1750. They'd been sick for, on average, 36 months, and they're on standard medical therapy, state-of-the-art at the time of study enrollment. Baseline measures, randomized to receive over 106 weeks, CoQ 300 milligrams a day or placebo. You repeat the baseline measures at 16 weeks, follow them for 106 weeks, looking at primary and secondary pre-specified outcomes. Now, the researchers behind coenzyme Q read all the papers, and I've read all these papers myself, and most of them are positive. A few studies showed no effect. No study showed a negative effect of coenzyme Q supplementation. But if you look at the studies where CoQ didn't do much, they didn't get the level up very high. But the positive studies, they got the level up. So basically, we're looking for a level above 2.5. That would seem to be the level at which you're going to get the maximum benefit from CoQ. If you give a low dose of CoQ and the level is low, you can't really expect much from that methodology. So we will measure CoQ levels in our patients. Now, 1.3 is normal for the normal healthy population, but we're not talking about normal healthy people. We're talking about people with heart disease, pump dysfunction, or patients with coronary disease. So we want to crank that level up. And the patients all understand this now, and they understand that we need to give enough coenzyme Q to get the job done. So they picked 300 milligrams a day so they could get the level above 2.5. So what happened with Q-SYMBIO? At 16 weeks, both groups improved with respect to functional class, symptom score, 6-minute walk test, and of course there's always going to be a placebo effect in any clinical trial. No significant differences in heart rate and blood pressure or their echo findings. However, pro-BNP did fall with coenzyme Q therapy. The blood level tripled as you'd expect, and there was a decrease in all-cause mortality at 16 weeks. They didn't give the number, the exact numbers in the study, but they said there was a decrease in all-cause mortality at 16 weeks. So that's just 4 months. That's not that long a time frame for us to assess the long-term therapy of CoQ or any other therapy in heart failure. But 106 weeks, the percentage of patients who improved by 1 New York Heart Association functional class, if you went from 4 to 3 or 3 to 2, was better, 58% versus 45% with CoQ versus placebo. Now here we've got pro-BNP. It was high at baseline. It's in both groups, obviously. At 16 weeks, it rose with placebo therapy. It fell with CoQ. At 106 weeks, it fell in both groups, but it fell more with CoQ therapy. So that's a laboratory marker of myocardial stress or strain. It fell with CoQ. Major adverse cardiovascular event rates at 106 weeks, 26% with placebo, 15% with coenzyme Q. So you add CoQ to maximal modern-day medical therapy, you get a significant decrease in adverse event rate, 43% reduction, and in particular, death from heart failure. 1 CoQ-treated patient died from heart failure. 10 placebo patients died from heart failure. So death from pump dysfunction was dramatically decreased. Most of our patients with heart failure now die of an arrhythmia. And of course, we can address that with defibrillators, so you can't die from VTAC or VFib if you got a defibrillator in place, but you could still die of pump failure, and that risk was lessened dramatically with coenzyme Q. Hospital stay, etc. All these parameters, hospital stay for worsening heart failure fell by 50% with CoQ. Cardiovascular death, 43% reduction, relative reduction, 16%, 9%. All-cause mortality fell. There was a 42% reduction from 18% to 10% of the subjects. And here we have event-free survival, and survival there was a benefit of coenzyme Q. And of course, it takes a little time for this effect to show itself because it takes time to rectify myocardial energetics, to improve pump function, to improve endothelial function. Again, it takes time to turn a ship around, but the ship was at least partially turned around with coenzyme Q therapy. Adverse effects. None, essentially, 19% nuisance adverse effects with placebo. There were few adverse effects with coenzyme Q because coenzyme Q is going to improve the function of every organ in the body. So you would expect that non-cardiovascular event rate would also decrease, and that appears to be the case. What if we just give coenzyme Q and selenium to older individuals who are at greater risk of cardiovascular mortality or mortality in general? Would that improve outcome? So here we're going to look at 443 clinically stable seniors who lived in Sweden, 72% hypertensive, 20% diabetic, 20% had known coronary disease. Baseline studies randomized them to receive CoQ, 200 milligrams a day, and selenium, 200 micrograms per day. So of course, selenium is going to support glutathione peroxidase and any glutathione-related enzyme system. So you're going to give CoQ and selenium. You might expect a synergy because they're working at different levels. You're going to follow them for 5.2 years. 53% of the placebo patients dropped out. 44% of the active treatment group dropped out. Fewer dropouts, probably because they felt better, and we'll use intention to treat for analysis. Double-blind protocol was utilized. So what do you see? Cardiovascular mortality, 12.6%, 5.9%. All-cause mortality, 16.2%, 12.6%. Pro-BNP rose in these seniors on placebo. It did not rise with the antioxidant group, so there was some protection against myocardial dysfunction in this population of seniors. Now here we're going to have event-free survival, and you do much better with the CoQ group than with the placebo group. These were predictors of all-cause mortality, cardiovascular mortality. The most important protective factor was being on coenzyme Q, dramatically decreasing your risk of cardiovascular mortality by over 50% and by over 20% for all-cause mortality. So the CoQ was protecting you not just against cardiac death, but against death from dysfunction of other organ systems, as you would expect. Whenever a molecule is good for the heart, it tends to be good for, whenever a nutraceutical molecule is good for the heart, it tends to be good for every organ system in the body. We can't say that for pharmaceutical interventions. So coenzyme Q is of value within the integrative approach to the patient with coronary insufficiency or heart failure. Now let's turn our attention to carnitine. Carnitine's job is to transport fatty acids, acyl groups, into the mitochondria, where the acyl group will be efficiently metabolized to generate a high yield of ATP. So we don't want to burn fatty acids in the cytoplasm. That's inefficient. We want them to go into the mitochondria. So we'll bind the fatty acid to carnitine to create an acyl carnitine that is transported across the mitochondrial membrane. The fatty acid is released. The fatty acid will be cleaved into 2 carbonacetyl groups, and you enter the Krebs cycle and onto electron transport. That's very efficient. This process requires carnitine and it requires riboflavin. The heart prefers to burn fatty acids. It will burn glucose as a secondary energy source. The brain, conversely, can only burn sugar. It can't burn saturated fats. So within the heart or the brain or any cell in the body, the 6-carbon glucose molecules will be cleaved again into 2 carbonacetyl groups. the acetyl group will bind to CoA, you'll get acetyl-CoA, and on into the Krebs cycle. So we can efficiently burn fatty acids and glucose in the presence of oxygen to make the ATP that we need to run our biology. However, in oxygen deficiency, we have to shift to anaerobic metabolism. What is the mechanism that determines when we shift from efficient oxidative to inefficient, but still life-sustaining anaerobic metabolism? So the first thing that goes wrong in oxygen deficiency is acetyl-CoA cannot be metabolized within the Krebs cycle. Therefore, levels of acetyl-CoA rise, and of greater importance, the ratio of acetyl-CoA to free CoA rises. That ratio, again, Mother Nature doesn't work with absolutes, she works with ratios. When the ratio of acetyl-CoA to free CoA rises, that triggers the shift to anaerobic metabolism. Stated otherwise, we go anaerobic not due to absolute oxygen deficiency, but due to a buildup of acetyl-CoA relative to free CoA. So Mother Nature did not design us well to deal with regional ischemia. We're going to go anaerobic even when some precious oxygen is still available. And the reason is Mother Nature never planned on regional ischemia. Primitive man did not have peripheral vascular disease. Primitive man didn't have strokes. Primitive man did not have coronary atherosclerosis. When would primitive man need to go anaerobic? Well, if you fell into a lake and you didn't get up to the surface quickly enough and there's no oxygen, rather than die on the spot, it makes sense to go from a high efficiency aerobic to inefficient but still potentially life-sustaining anaerobic metabolism to keep you from dying until you break the surface. So we switch from aerobic to anaerobic prematurely when there's still oxygen left because of this switch that is triggered, a rise in acetyl-CoA to free CoA. Now, carnitine will help here because carnitine can bind excess acetyl groups, lowering the ratio. So if we have a buildup of acetyl-CoA due to hypoxemia and we throw in plenty of carnitine, we'll make acetylcarnitine and free CoA, and we're going to lower the ratio. So in the presence of carnitine, you can maintain high efficiency oxidative metabolism longer in a hypoxic environment. The problem is with each episode of hypoxia, you're going to lose carnitine. So in the situation of the myocyte in a heart attack or severe heart failure, there's a high level of acetyl-CoA, low free CoA, and you got no carnitine. You lost your buffer. If we replace the buffer with supplemental carnitine, can we rectify the situation, allowing the myocyte or the heart or the individual to maintain high efficiency oxidative metabolism and delay the switch to low efficiency anaerobic metabolism? Now, this appears to be the case, and I mentioned that carnitine levels fall in the patient with heart disease. Indeed, they do. If you do endomyocardial biopsies, you look at normal people, class 2, class 3, class 4 heart failure, as you would expect, as the severity of the pump dysfunction, the severity of heart failure increases, you see decrements in carnitine. Carnitine scores are reduced 50% in cardiomyopathy, 80% with acute viral, toxic, or alcohol-associated heart disease. Carnitine stores are also reduced in chronic coronary disease as a consequence of chronic hypoxemia. You use up your carnitine buffer, extremely low in muscle involved in acute heart attack, intermediate values in the border zone as you would expect. So can we intervene here? Absolutely we can. And there's dozens, if not hundreds, of studies showing benefits of carnitine in multiple cardiovascular scenarios. In coronary disease, angina frequency and severity and treadmill parameters improve. Post-bypass outcome improves. Heart failure, cardiomyopathy, claudication. There's a beneficial effect on lipids because you're improving energy metabolism. Triglycerides fall, and LPA, curiously, may fall. It's of use in cardiogenic shock. Intravenous carnitine improves outcome in cardiogenic shock. In patients experiencing acute MI, carnitine therapy decreases infarct size, blunts infarct expansion, improves short and long-term outcome. Let's present a few of these studies. So carnitine and heart failure. 900 milligrams of carnitine a day versus placebo over 8 weeks in patients with heart failure. 55% improved by at least one functional class. Ejection fraction rose in 44% of the subjects. Shortness of breath was relieved in 44%. Edema resolved in a third. Overall, 2/3 improved. 500 milligrams a day of propionyl carnitine. Here you're going to bind carnitine to propionic acid. This was an effort, I think, to make carnitine a prescription drug versus placebo over 180 days in patients with mild to moderate heart failure. Ejection fraction rose by 8% from 41 to 45% at 30 days to 47% at 90 days. Treadmill time increased by 16% at 30 days and by 26% at 180 days by 2 minutes from 7.6 to 9.6 minutes. All beneficial phenomenon because you're improving energy metabolism, you're prolonging aerobic high efficiency oxidation of fatty acids, therefore more ATP, better cardiac performance, fewer symptoms, improved functional status. Carnitine in cardiomyopathy. 70 patients with a non-ischemic cardiomyopathy. They had advanced disease, class 3 or class 4. They're on digoxin, diuretics, and ACE inhibitors, none on antiarrhythmic drugs. Give them carnitine 2 grams a day or placebo. You're going to follow them for 3 years. Atrial fib flutter occurred in 21% of the placebo patients, only 2% of those on carnitine. Presumably, better energetics, better cardiac performance, less rise in left atrial filling pressure, less impetus for fib flutter, or was the fib flutter due to bioenergetic failure in the atrial myocytes? We don't know, but anyways, there was less fib flutter. 7 of the 33 placebo patients developed atrial fib. 2 of the 7 responded to cardioversion amiodarone. Only 1 of the 37 carnitine patients developed flutter, responded to cardioversion. 3-year mortality falls from 16% to 2%. Wow, isn't that good? 6 of the placebo patients died, 5 from heart failure, 1 suddenly. Only 1 of the carnitine patients died from VTAC. Carnitine and post-MI status of mortality. 160 consecutive MI patients at hospital discharge randomized to receive, on top of standard therapy, carnitine 4 grams a day or placebo. Again, you got to give enough to get the job done. Otherwise, same care. Reevaluate at 1 year with respect to the carnitine treated patients versus placebo patients. Lower heart rate and blood pressure and cholesterol. Lower heart rate and blood pressure probably due to improved energetics. You don't need as many heartbeats to provide enough blood to meet the needs of the body. Therefore, there's going to be lower elaboration of catecholamines, lower heart rate, blood pressure, energy metabolism improves, so you have a lower cholesterol, angina arrhythmia less frequent, 1.2% mortality from a PE versus 12.5% mortality in the placebo group from heart failure recurrent MI. This was a study where they gave intravenous carnitine to patients with an acute MI, 100 milligrams per kilogram IV carnitine versus placebo, twice a day over 3 days. PVCs per hour, first day, second day were less with the carnitine therapy. Couplets per 24 hours were less. Episodes of VTAC, slightly more on day 1 with carnitine, none on day 2. Hours of VTAC decreased. So there was an acute antiarrhythmic effect of carnitine, presumably by salvaging myocardium, because if you throw a bunch of carnitine in there, you're going to prevent myocyte necrosis because you're going to be able to help recycle ADP to ATP, so you're going to have a smaller infarct. If you have a smaller infarct, less electrical instability, presumably less of an arrhythmic burden. Infarct expansion occurs due to stress or strain. So if you have an infarct, you have an anterior wall infarct, that area is hypokinetic or akinetic, the rest of the heart's functioning normally, there's a tendency for the infarcted wall to expand. That will cause dyssynchrony and is associated with an increased risk of heart failure and a poor outcome. So if you give patients carnitine 6 grams a day versus placebo for 1 year, you have lesser degree of infarct expansion with carnitine supplementation because you're preserving myocardium in the damaged region. The area is less likely to become fibrotic and then subject to infarct expansion. Carnitine and post-MI outcome, 101 consecutive CCU patients with an ACS, 80% had a Q-wave infarct, 10% with a non-Q-wave infarct, 10% had unstable angina, all get standard therapy, randomize them to carnitine, 2 grams a day or placebo. You're going to evaluate their status at 28 days, double-blind protocol followed. Lipid peroxides fall because you're having less oxidative stress, because you're improving myocardial energetics, fewer free radicals are being generated, lower lipid peroxides. LDH as a marker of cell membrane dysfunction, a marker of infarct size, the rise was attenuated with carnitine. They had lower levels of CPK. Their QRS score, which is an index of infarct size, was also lessened. So you get a more rapid reduction in oxidative stress, and they've got smaller infarcts because you're salvaging myocardium with carnitine. Event rate, 28 days. Angina, post-infarct angina, bad sign, falls from 36% to 18%. CHF frequency fell in a non-statistically significant fashion. Low ejection fraction pump dysfunction, arrhythmia was less, fewer non-fatal infarcts, fewer cardiovascular deaths. Total event rate at 28 days falls from 26% to 16%, simply with bioenergetic support with carnitine monotherapy. If you did a study and gave coenzyme Q and carnitine, you would probably have a synergy. That's not been done in humans, it's been done in animals, and a synergy was demonstrated as you would expect. Now, we need high levels of ATP, so we need to recycle ATP from ADP. The most efficient approach here is mitochondrial oxidative phosphorylation, which requires adequate oxygenation. That's highly efficient. Now, if we run out of oxygen, we have 10 heartbeats of energy in the form of phosphocreatine. So ATP can donate a high-energy phosphate bond to creatine to create a reserve of phosphocreatine. So we've got 10 heartbeats here in phosphocreatine. Of course, if we do not have any oxygen, we have to switch to glycolysis, anaerobic metabolism. It is very, very, very inefficient. That's a poor way to recycle your ATP. Now, if we run out of adenine nucleotides completely, and we have to start from scratch building adenosine to phosphorylate to AMP and then to ADP to ATP, that's incredibly slow and it's incredibly expensive. So de novo ATP synthesis is slow and metabolic expensive. It takes 9 ATPs to form one new ATP via the process of de novo synthesis, and it takes 100 days for complete ATP regeneration. So that is a situation that we obviously wish to avoid. And typically we can, because when oxygen, calories, and cofactors are available, ATP is split to phosphorylate another molecule to do work, creating adenosine diphosphate and phosphate. So then we will simply burn some sugar and fat, aerobically preferably, tack that phosphate group back onto ADP to make more ATP to recycle. However, when oxygen is not available, heart disease, vigorous exercise, when we are hypoxemic, so we're going to split the ATP to ADP to do work, but there's no energy, we cannot rephosphorylate ATP. So now we got a problem. Well, again, we have 10 heartbeats with respect to phosphocreatine stores. So phosphocreatine can donate a high level, a high energy phosphate bond to ADP to make ATP. Now, ADP can be split into to create ATP and AMP. That gives us a few more heartbeats. But then we burn ourselves down to AMP, which is then converted to adenosine and phosphate. Now, AMP, ADP, and ATP contain a charge. They will not cross the cell membrane. Adenosine is not charged. It will diffuse out of the cell membrane and it will be lost forever. So if we have this situation with severe oxygen deficiency, we're going to burn our ATP off to adenosine and it will diffuse from the cell and it will be lost. Well, if we reoxygenate, such as thrombolytic therapy or acute interventions, or when the patient undergoing on-pump bypass surgery is taken off the pump, the heart is started again, and the heart is reoxygenated, well, oxidative phosphorylation can resume. We now have oxygen, we now have calories, we have cofactors, we got plenty of phosphate, but we have no more ATP. We ran out of adenine nucleotides, so while oxidative phosphorylation is back in business, we're not back in the ATP regeneration business, and we will be stunned. So this could be a myocyte, a region of the heart, or the entire heart, say in an animal model where you're taking the heart and exposing it to total global ischemia, or a human heart undergoing on-pump bypass surgery. It will be deprived of oxygen for a period of time until the heart starts up again, so there's going to be some ATP loss. So as we go with progressive hypoxemia, we're going to run out of ATP within the myocyte or the myocardium. If we resupply oxygen at 1 hour, we'll get back into the ATP generation business, but we won't get back to baseline because a small percentage of the adenine nucleotide pool has been burned down to adenosine and lost forever. The longer the time period through which the myocyte or the heart is deprived of oxygen, the greater will be the percentage of adenine nucleotides that are burned down to adenosine and lost. So if you resupply oxygen, you can start making ATP, but you see that with resolution of hypoxemia, you're not going to have adequate levels of ATP for proper function. So the longer we're hypoxemic, the greater will be the percentage of our adenine nucleotide pool that is lost forever as it's converted to adenosine, and it will diffuse out of the cell. So if we burn off our ATP down to AMP, down to adenosine, the adenosine leaves the cell. We resupply oxygen, we have no AMP to work with, we have no AMP to phosphorylate back to ATP, and we have stunned myocardium. And the myocardium will remain stunned until we can generate new AMP, which is energy intensive and it's very slow. However, the rate limiting step in regenerating AMP from adenine is the quantity of PRPP, which is phospholipase in the cell. If we supplement with ribose, we can jumpstart phospholipase production, and then we can rapidly begin to return the adenine nucleotide pool back to normal. We can start making AMP that can be phosphorylated ATP. So we can deal with stunning with ribose supplementation. This is an animal model of total global ischemia. So total global ischemia for a period of time, and then you look at the ATP recovery rate. Early on during this situation of ischemia reperfusion phenomenon, in the control animals, you're still not making ATP because you don't have any AMP to work with. But in the ribose-treated animals, you can start recycling your adenine nucleotide pool. You're making AMP because of the ribose supplementation, and you can phosphorylate it back to ATP. So in the placebo animals, you're even at 1 to 2 days, you're having a lot of trouble generating ATP, whereas ATP recycling has been jump-started with ribose therapy. With this work in humans, 20 subjects with an ejection fraction above 35% scheduled for on-pump valve replacement and or bypass. So if you have on-pump surgery, the heart during the time of surgery does not have any blood supply. So those myocytes will become hypoxemic and anoxic. And if the surgery is prolonged, the heart cells will begin to die. Well, to decrease the likelihood of death, the heart is fibrillated, so it's not working. It doesn't require oxygen, and it's placed on ice, put in a hibernation situation. And then when the surgery is over, the heart is started again, and it's resupplied oxygenated blood. But the longer the surgery goes, the greater will be the degree of burn-off of the heart's adenine nucleotide stores down to adenosine that will be lost. Therefore, you're going to have stunning. So when you have on-pump heart surgery, there's always a degree of myocardial stunning. There's going to be diastolic dysfunction. Early on, there may be systolic dysfunction requiring pressor therapy. If we intervene here with ribose, will we prevent that? And intuitively, you would say yes. Let's look at that in this study. So these 20 subjects that underwent on-pump surgery where a certain percentage of the myocardial adenine nucleotide pool will be lost. At cross-clamping, begin a 5-day drip of D5-NW or ribose 70 grams a day in D5-NW. Measure ejection fraction 7 days post-op. So in the D5-NW group, despite successful surgery, 80% had a 15% or greater fall in ejection fraction from baseline. So surgery is successful, but because of the adenine nucleotide burn-off, they weren't able to make ATP, and they had pump dysfunction post-op. And 80%, only 20% with ribose. Therefore, if every patient undergoing bypass surgery was treated with ribose, we would expect better outcomes. The same thing with coenzyme Q and carnitine and antioxidants and allopurinol. If you lower oxidative stress, if you preserve the myocardial adenine nucleotide pool, you're going to recover more readily and completely from bypass surgery. Ribose in congestive heart failure. 15 subjects with ischemic cardiomyopathy, mean ejection fractions 47%. Randomized them to ribose 5 grams 3 times a day, dextrose placebo. Double-blind protocol was followed. Atrial velocity time integral and left atrial volume decreased. So left ventricular ejection fraction did not change, but there was a reduction in left ventricular filling pressures because there was an improvement in diastolic dysfunction. Therefore, there's going to be a lower left atrial volume because left ventricular end-diastolic pressure fell. So diastolic function improved. Quality of life improved, physical functioning score improved. So just as coenzyme Q and carnitine are helpful, ribose is helpful in this patient population. Ribose in exercise-induced ischemia. 20 men with stable but severe coronary disease, reproducibly abnormal stress study. They had angiographic evidence of coronary disease, do a maximal stress test on day 1, repeat on day 2. And by carrying out stress studies 2 days in a row, you're going to create ischemia and you're going to burn off some of the adenine nucleotides. So if you do a stress test on your patient every day for 2 weeks, at the end of 2 weeks, they're probably going to have more angina and their treadmill times will be lower because we've depleted their adenine nucleotide pool. So they did that and then randomized to receive 3 days of ribose, a fairly high dose. We typically use 5 grams 3 times a day. They use 15 grams 4 times a day or placebo. Repeat the stress test on day 5. Double-blind protocol was followed. Time to moderate angina increased in both groups, but it increased a lot more with the ribose therapy. Time to ST segment depression increased by a minute with ribose versus essentially no change. So with placebo therapy, so by repleting the adenine nucleotide pool, you were better able to recycle ATP. ST depression is a sign of ATP deficiency. They had less ATP deficiency, so time to ST segment depression was prolonged, and they're going to have an improved functional status and less angina. Taurine is the most abundant free amino acid in heart muscle. It's concentrated from plasma at a 200-to-1 ratio. So the heart needs a lot of taurine. It's going to concentrate it within the myocytes. Taurine has a positive inotropic effect. It enhances the positive inotropic effect of digitalis, but it's also a digitalis buffer, and it blunts toxicity due to digitalis excess or high levels of catecholamines. It's a calcium modulator. It has a positive inotropic effect in the hypocalcemic heart, but it protects against heart damage due to calcium excess, so it buffers calcium. It's involved in magnesium homeostasis. Without taurine, the heart has trouble maintaining its magnesium pool, so if you supplement with carnitine, myocardial magnesium content will increase. It upregulates endothelial nitric oxide synthase, function and transcription, improves endothelial function, thus providing an antioxidant effect. Because if endothelial function is improved, you make nitric oxide, not superoxide. Taurine levels rise in the heart under strain. Heart failure, left ventricular hypertrophy, as the heart is trying to cope, while taurine levels will fall in the hypoxic heart. So let's examine some of the studies of taurine in various cardiovascular syndromes. Let's look at taurine and endothelial function in type 1 diabetics. 19 less than 30-year-old men, none with hypertension, none with obesity, none with hyperlipidemia or smoking. 9 were diabetic, 10 were non-diabetic. So these were like pure diabetes versus non-diabetes. No other risk factors were involved. Measure endothelial function, brachial artery flow-mediated vasodilatation, randomize the diabetic subjects to receive over 2 weeks taurine 1,500 milligrams a day or placebo, repeat the endothelial assessment, cross over to the opposite group and restudy. Thus, a randomized double-blind crossover protocol was followed. Flow-mediated vasodilatation was impaired in the type 1 diabetics versus the healthy controls. Placebo therapy had no effect. Taurine improved flow-mediated vasodilatation back to that of a normal healthy individual. Augmentation index, a low value means greater elasticity of the blood vessel. The vessels were stiff, and that was also rectified with taurine supplementation in the type 1 diabetics. Taurine effect in smokers. 30 healthy subjects, none hypertensive or diabetic, none with a family history of hyperlipidemia or premature coronary disease. So no other risk factors except half were smokers, half were non-smokers. Measure endothelial function. As a second study, we're going to take human umbilical vein endothelial cells, incubate them with monocytes obtained from study participants, and measure in vitro nitric oxide generation. nitric oxide synthase 3 expression, endothelin production. When you have endothelial dysfunction, you don't make nitric oxide, you make superoxide, and you make endothelin. Treat the smokers with vitamin C, 2,000 milligrams a day, or taurine, 1,500 milligrams a day. Repeat the functional studies. We would expect that vitamin C would have some effect on endothelial function because it neutralizes superoxide. What effect will taurine have? So let's look at nitric oxide generation. Endothelial function was poor in the smokers. They were not making nitric oxide. If you treat them with taurine, they're back in the nitric oxide generation business. In fact, they're making more nitric oxide than the healthy controls. Endothelin-1 expression was increased in the smokers because they had endothelial dysfunction. That was rectified with taurine supplementation. Brachial artery flow meter dilatation was terrible, 1% in the smokers versus 11% of the healthy controls. Vitamin C helped because you were neutralizing superoxide. Now, long-term vitamin C may have helped more, but short-term vitamin C, it helped, but the best result was with taurine to rectify endothelial dysfunction. And if you look at transcription of nitric oxide synthase, it is upregulated with taurine. So taurine is improving endothelial function, probably indirectly with an antioxidant effect, and probably directly by increasing transcription of nitric oxide synthase. Taurine plus coenzyme Q, what effect will combination therapy have on post-MI outcome? So here we're going to take 51 CCU patients with suspected MI. Some had infarcts, some had unstable angina. All get standard ACS, post-infarction medical therapy, randomize them to double placebo or a cocktail of taurine, 6 grams a day, and coenzyme Q 120 milligrams a day. You reevaluate it 4 weeks. Double-blind protocol was followed. Malondialdehyde is a marker of oxidative stress, specifically oxidation of cell membrane fatty acids. This would be akin to LDL oxidation. The farther you get away from the infarction, the lower the level of oxidative stress. So, of course, malondialdehyde would fall in both groups. As you can see, it falls more readily in the coenzyme Q and taurine group because in this group, there was some squelching of free radicals by coenzyme Q. If you have better myocardial energetics, you're going to have less oxidative stress. So, yes, you would expect malondialdehyde levels to fall in response to CoQ and taurine supplementation. Now, the supplemental cocktail was coenzyme Q and taurine, not vitamin E and vitamin C, but when you're experiencing oxidative stress, you're going to be using up your E and C. With placebo therapy, there was a slow reconstitution of the vitamin E and vitamin C stores, and they restored much more readily due to the antioxidant protection provided by CoQ and taurine. You would expect that. They had smaller infarcts with less CPK release, their QRS score was lower, so there was an antioxidant effect, and myocardium was spared. You had a smaller infarct. Event rate at 28 days, recurrent angina, we don't want to see that. Following an infarction, it means there's myocardium at risk, falls from 23% to 8%, less heart failure, less prolonged QT, frequent PVCs or less. Total post-infarct complications falls from 81% to 24%, death and reinfarction 31% to 12%. That would seem to be a good idea. Taurine and chronic heart failure. 62 patients with class 2 to 4 heart failure on standard drug therapy, randomized to receive over 4 weeks, 2 grams of taurine 3 times a day or placebo, cross them over to the other side, etc. No significant improvement in various manifestations of heart failure with placebo therapy, whereas dyspnea, palpitations, crackles, etc., improved in a statistically significant fashion with taurine supplementation. New York Heart Association functional class improved by 1 point in 28% of those on taurine, only 10% with placebo. Deterioration, only 2% with taurine, 10% with placebo. There was a physician assessment as well. So adding taurine to conventional therapy improves symptoms, signs, physician assessment, and New York Heart Association functional class in patients with heart failure. Magnesium. I won't dwell on magnesium because we all appreciate that magnesium has an antiarrhythmic effect, anti-inflammatory effects. It's of value in energy metabolism to recycle adding nucleotides to ATP. I'll present a study showing that magnesium improves endothelial function. I don't practice hospital acute care cardiology anymore, but I did. And when I did, I used a great deal of intravenous magnesium to terminate arrhythmias. Chronic magnesium supplementation, of course, has a beneficial effect on arrhythmia frequency and severity. Magnesium is a cofactor for COMT, catechol-methyltransferase, so we need magnesium to break down catecholamines. There is an anti-inflammatory effect. One study showed that magnesium lowered C-reactive protein. And of course, we all understand that diuretics, thiazide diuretics and loop diuretics will deplete magnesium. So if we have a patient with heart failure and we're treating with diuretic therapy, we must measure and supplement as required magnesium. Magnesium and endothelial function. Let's look at 187 subjects with stable corneal disease, record at baseline intracellular magnesium level. What they did, they carried out a buccal swab evaluation and looked at the intracellular levels. Brachial artery flow-mediated vasodilatation is a measurement of endothelial function. Treadmill and clinical parameters. Randomized the subjects after doing the baseline measurements to placebo or magnesium citrate, 365 milligrams a day. Repeat the baseline assessments at 6 months. Intracellular magnesium levels were low in these patients with chronic corneal disease, 33 milliequivalents per liter versus 38 in healthy controls. 6 months of placebo therapy had no effect. 6 months of magnesium raised intracellular magnesium levels, not to that of a normal individual, but intermediate between placebo therapy and normal individuals. Presumably a higher dose or a longer period of supplementation would have increased the intracellular magnesium levels to normal. However, they got the magnesium levels up enough because flow-mediated vasodilatation, abnormal at rest, quadrupled into the normal range at 16% with magnesium. So magnesium supplementation will increase intracellular magnesium levels, and this translates to an improvement in endothelial function in patients with chronic corneal disease. As the most important predictor of outcome is endothelial function, we would anticipate that magnesium supplementation would improve the outcome of our patients, and indeed, we all know that to be the case. Treadmill time did not improve with placebo therapy. It did improve from 8.1 to 8.7 minutes with magnesium. They looked at the data with respect to treadmill time in relation to your exit magnesium level. Those who had higher exit magnesium levels from supplementation, their treadmill time was 9.1 minutes. Those with lower exit magnesium levels were treadmill time was only 6.9 minutes. Angina occurred during treadmill testing in 21% of the subjects on placebo therapy, 8% of magnesium. Time to angina was prolonged from 6.2 to 6.9 minutes. There was less ST depression, 50% with placebo, 42% with magnesium. Time to ST segment depression was prolonged from 3.6 to 4.4 minutes. Exercise duration change in exercise duration related to change in magnesium level. If you had the lower your magnesium level at baseline, the higher your magnesium level on treatment, the greater was your incremental improvement in exercise duration. So magnesium is a winner. Let's talk about Terminalia arjuna. This is a deciduous tree found throughout India. The supplement is an alcoholic extract of the dry bark. Its cardiotonic use was first described in 500 BC. It's been utilized for 3 centuries within Ayurvedic medicine. There are many components. Some of them we are not familiar with. Others, such as bioflavonoids, we are familiar with, and we understand their benefits as antioxidants. The therapeutic uses of Terminalia, it's a standard therapy in India. It's used to treat hyperlipidemia. In an animal model where you overfeed animals a high lipid diet, there's an attenuation of the diet-induced atherosclerosis with Terminalia. It improves endothelial function. It's of value in hypertension, angina, and in congestive heart failure. Let's look at a study of Terminalia in heart failure. 12 subjects with treatment refractory but stable New York Heart Association Class 4 heart failure, symptoms at rest. Now, this group of 12 patients was obtained from an initial group of 136 patients hospitalized with heart failure. They were treated intensively with diuretics, spironolactone, vasodilators, and 124 improved to class 3 or less. 12, despite maximal hospital therapy, remained in class 4, so they were eligible to participate in this study. So you do the baseline study, baseline assessments, randomize these class 4 heart failure patients to receive over 2 weeks, Terminalia Arjuna, 500 milligrams 3 times their placebo. You cross them over to the opposite regimen. Thus, this was a randomized double-blind crossover protocol that they utilized. Heart rate and blood pressure. Systolic blood pressure tends to be low in patients with chronic heart failure, and that limits vasodilator therapy, limits beta blocker therapy. A rise in systolic blood pressure is desirable. Systolic blood pressure rose with Arjuna, but not with placebo therapy. Conversely, we would like to have a lower diastolic blood pressure. Diastolic blood pressure dipped a little bit with Arjuna, not with placebo. Heart rate fell with Arjuna, so you have better contractility, better cardiac performance, thus a lower heart rate. There was a resolution of what we might call a compensatory tachycardia due to the pump dysfunction that was attenuated with the Arjuna. Weight rose with placebo therapy, fluid retention, it fell with Arjuna. Potassium levels rose, so there's some potassium in Arjuna. That's a plus because most of our diuretics are depleting magnesium. Ejection fraction did not change with placebo therapy. It rose from 30% to 35% with Arjuna, and diastolic volume and systolic volume also decreased. So pump function improves, contractility is improving. Heart failure functional class. Now at baseline, they're all in class 4. With placebo therapy, they're all in class 4. With Arjuna therapy, they all improved to class 3. So they're class 4 heart failure despite intensive diuretic therapy, spironolactone vasodilators. You add Arjuna, and they all move out of class 4. There was clinical and functional improvement, no tolerance issues, so you're going to send them home. This was the first 2 weeks was done in the hospital. Send them home with Terminalia, 500 milligrams 3 times a day, and their usual meds. So we got these 12 now class 3 heart failure patients sent home with Terminalia. Improvement was maintained. They all went back to work. Their diuretics were decreased in all 12. At 4 months, 9 of the 12 are in class 2. 3 of the 12 are still in class 3. 10 are alive at 24 months. 1 died of a stroke at 16 months. 1 died suddenly at 14 months. But the expected mortality in this group in 1995 would be 40%. 1 adverse event was a embolism of the popliteal artery that was addressed medically. So adding in Terminalia to standard medical therapy in people with refractory heart failure, you get a benefit that is sustained. Terminalia in lipid management. 105 patients with stable coronary disease, not on lipid-lowering drugs. Over 4 weeks before you collect the data, you hold their antioxidants, you put them on the American Heart Association Step 2 diet. Baseline study randomized to receive over 30 days Terminalia, 500 milligrams daily, and or vitamin E, 400 IUs daily. And then you repeat the baseline studies, randomized double-blind protocol was followed. Cholesterol rose slightly with placebo. It fell insignificantly with vitamin E. We don't expect vitamin E to lower cholesterol, but it did fall significantly from 196 to 175 with Terminalia. LDL dropped from 119 to 97. No major change in triglycerides or HDL with placebo, vitamin E, or Terminalia, but there was a hypolipidemic and LDL lowering effect. Lipid peroxides fell slightly, thus there's a slight antioxidant effect. So we're lowering lipids, we're having an antioxidant effect, so thus we would be lowering LDL oxidation. Hawthorne Berry. I think we're all familiar with Hawthorne Berry. We've heard about Hawthorne Berry. It contains a number of compounds, primarily bioflavonoids, oligomeric proanthocyanidins. Clinical uses of hawthorn. It's widely used in Europe. There's a standardized extract that is prescribed as a pharmaceutical. In Europe, it's used to treat GI disturbances, hyperlipidemia, hypertension, angina, and heart failure. How does it work? It provides a positive inotropic effect that's concentration dependent. There's a cyclic AMP independent inhibition of sodium potassium ATPase, kind of like digoxin, improved energy turnover in the myocytes. There's an antiarrhythmic effect. It prolongs the action potential and refractory period, and it's protective in animal models of ischemia and heart failure arrhythmia. It will phosphorylate serine 1177 in nitric oxide synthase, and that will upregulate nitric oxide synthase expression. Thus, endothelial function will improve. It has ACE inhibition and antiplatelet effects. There was a paper published 30 years ago comparing Hawthorne to captopril in the treatment of heart failure, and Hawthorne did just as well as captopril. It has an antioxidant effect and some anti-inflammatory properties. It's said to be a coronary vasodilator. I don't know if that's been proven. I've not found a paper, but it's said to be a coronary vasodilator. And in animal models, it protects against apoptosis of the myocardium and the endothelium, and it protects against ischemia reperfusion injury in animal models. Let's look at one study of Hawthorne Berry in heart failure. 209 subjects with class 3 heart failure. They're having symptoms at less than 2 blocks, less than 2 flights of stairs. They've been stable for 6 months, and they've all were treated with a diuretic plus or minus an ACE inhibitor. So for the study, you hold all their prior meds, treat them for 4 weeks with a diuretic, hydrochlorothiazide and trimamdorine, baseline studies, and randomize them to receive WS. This is a standardized extract of Hawthorne, low dose, 450 twice a day or 900 twice a day, or placebo. Repeat the baseline studies 4 months, randomized double-blind, multi-center protocol was followed. Maximal workload on a bicycler ergometer improves a little bit with placebo from 54 to 58 watts. With low dose Hawthorne, there's no significant difference. With high dose Hawthorne, there is an increase at 16 weeks in workload. Now, you don't see a whole lot at 8 weeks. You have to be patient. At 16 weeks, there was an increase in maximum workload. Maximum workload achieved. No real change with the low dose, but with high dose, 52% were able to increase their maximum workload. Only 6% noted a deterioration in maximum workload. So the high dose Hawthorne was the value here. Symptom score decreased with placebo. Placebo did just as well as low dose Hawthorne. High dose Hawthorne did a little bit better. Here, a lower score being favorable. Investigator and subject assessment of efficacy, very good with the high dose of Hawthorne for both the investigator and the individuals involved in the study. So low dose was not that effective, but high dose Hawthorne did have a beneficial effect in symptoms of heart failure and performance, functional status, how far you could go on the bicycle ergometer. Subject assessment of tolerability, it was very good in terms of adverse events, side effects. Hawthorne use was associated with fewer adverse events than placebo. So some of these adverse events might have been, these side effects may have been due to heart failure that was attenuated. Of interest, vertigo occurred in 10% of the subjects on placebo and far fewer in those on Hawthorne. I don't know why that was. Maybe it was a bioflavonoid effect, but anyways, so I thought it was interesting that there was less vertigo with Hawthorne Berry. So these patients are getting better with their functional status and performance, and they're having fewer nuisance side effects, which were presumably related to or aggravated by their heart failure. Hawthorne effect on outcome in advanced heart failure. 2,681 subjects with class 2 through 3 heart failure. Some were ischemic, some were hypertensive, some had a non-ischemic dilated cardiomyopathy. To be in the study, the ejection fraction had to be 35% or less. They're all put on standard medical therapy, state-of-the-art at the time. 63% were on 3 different drugs. Baseline studies randomized them to receive Hawthorne. I think I have an error here. I think this is 900 twice a day. The paper is buried in the basement, and I'll have to dig it up, but I'm pretty sure it was 900 twice a day, or placebo. Follow for event rate. And the primary endpoint was the time to first cardiovascular event. Will Hawthorne Berry therapy as an add-on delay the time to your first adverse event? Randomized, double-blind, multi-center protocol was followed. Now, time to first cardiovascular event was prolonged by Hawthorne, but only slightly. From 606 to 620 days, 2-year event rate was decreased slightly. 28.9% with placebo, 27.7% with Hawthorne. So there was a difference, but it was not a marked difference. It was not statistically significant. So 2-year event rate, no real major dramatic changes, just slight decreases. cardiovascular mortality was decreased by just below 10%. Sudden death was decreased by 15%. Those are going in the right direction, but they were not statistically significant. Now, if you evaluate the data, to be in the study, your ejection fraction had to be 35% or below, somewhere in the 15 to 20% range. If you then look at the subjects that had less severe pump dysfunction, their ejection fraction was 25 to 35%. You get rid of those with 24% or below. Then there was a statistically significant benefit on mortality. There was a 20% mortality reduction and a 49% reduction in sudden cardiovascular death. So in the patients that aren't too far gone, adding in Hawthorne Berry had a statistically significant benefit. In the entire study, the benefit was just, borderline. But, the message here is that Hawthorne Berry is effective as an add-on therapy to standard drug therapy in our patients with heart failure. Thiamine supplementation in heart failure. Does furosemide-induced thiamine deficiency aggravate heart failure? Will supplemental magnesium reduce symptoms and improve cardiac performance in our furosemide-treated heart failure patients? So we all get it that diuretics waste potassium. We all get it that diuretics waste magnesium. What about B vitamins? We need B vitamins to generate energy. As it turns out, high-dose diuretic therapy will recapitulate cardiac beriberi. So thiamine supplementation is appropriate. Let's examine this. 30 subjects with chronic heart failure, they all had advanced disease, ejection fraction below 45%, New York Heart Association class 2 through 4. All were on at least 80 milligrams a day of furosemide for 3 months, so high-dose diuretic therapy. What they did, they hospitalized all 30 subjects for 1 week. Home meds are continued, all receive a standard hospital diet, which has only 1 milligram of thiamine a day. Then they were treated with 100 milligrams of thiamine or placebo IM twice a day for 1 week. So you're going to get aggressive thiamine repletion, reevaluate the lab studies and clinical status, randomized double-blind protocol. Then after they completed the hospital portion of the study, they discharged all 30 home on thiamine, 200 milligrams a day on the usual meds, and then you reevaluate at 6 weeks. So thiamine levels were low and placebo had no effect. Thiamine levels rose from 4.3 to 90 with thiamine supplementation, 100 milligrams IM twice a day. The TPPE effect has to do with the rate of an enzyme with or without thiamine supplementation. So it's an in vitro study and a low level is good. And they all had high TPPE levels consistent with a functional deficiency in thiamine with supplementation that improved. Urine output and sodium excretion did not increase with placebo therapy. They both improved with thiamine supplementation. Ejection fraction rose from 26 to 28%, 2 points or 7% overall. With placebo therapy, ejection fraction rose 14% with thiamine from 28% to 32%. So they demonstrated that intramuscular thiamine raised thiamine levels, improved ejection fraction, and improved cardiac performance, manifested by an increased urine output and increased sodium excretion in these diuretic treated patients with heart failure. So now you're going to send them all home on 200 milligrams a day to maintain thyroid adequacy. Their thiamine levels rose to 50. The TPPE effect was favorable in all of them. Ejection fraction rose from 27% of hospital discharge to 33%, 6 points or a 22% rise, which we are pleased with. So nutritional recommendations, and I'm going to kind of lump these in for heart failure, cardiomyopathy, post-heart attack outcome. A broad spectrum vitamin mineral supplement of 6 a day like we used in TAC 1 and TAC 2. Fish oil 1 to 4 grams a day. CoQ, if I had to pick a dose, I would say 300 milligrams. You want to get the level to 2.5. Carnitine 1 to 2 grams a day, keeping in mind some of the studies used up to 4 grams. Ribose is 5 to 10 grams 3 times a day. If you have heart failure, if you have ischemia. If you don't have heart failure or ischemia, you don't really need ribose. You need ribose only if you're going to be burning your ATP down to adenosine and having trouble recycling it. Magnesium to bowel tolerance. If the patient can't tolerate oral magnesium, we can use topical magnesium. We can use IM magnesium. We want to get a normal intracellular level or a normal red cell magnesium level. We really can't go wrong with magnesium. We're not going to hurt anybody with magnesium unless they have renal failure. We use IV magnesium all the time. It is metabolized rapidly, so we can be very liberal with magnesium. Arginine, 6 to 12 grams per day. Patients want to take 500 milligrams once or twice a day. That won't work. And all the published studies of arginine in heart disease, endothelial function, use a minimum of 2 and more likely 4 grams 3 times a day. It does not have a long half-life. Taurine, 1 to 6 grams a day. Taurine is the most abundantly conserved amino acid in the heart. It has a positive inotropic effect. It improves endothelial function, and it helps the heart utilize magnesium. Thiamine, which is being wasted in diuretics. Testosterone to achieve physiologic free testosterone and estradiol levels is of value in heart failure. That's been demonstrated. We don't want super physiologic testosterone. We want physiologic testosterone. There's a role for vitamin D. K2 doesn't have a role in heart failure, but it has a role in the prevention of vascular calcification. We've shown that Terminalia, 500 milligrams 3 times a day, and Crataegus oxycantha, that's the botanical name for hawthorn, is of value, particularly if we could get our hands on the European extract. Unfortunately, we can't, but hawthorn is of value to your patients. If patients are having nuisance arrhythmia, and you don't really want to put them on a drug, they don't need to be on a drug, but they're having palpitations, they're tense, put them on magnesium to bowel tolerance and Hawthorne Berry, roughly 600 milligrams twice a day. You're not going to hurt anybody. Most of the time, their palpitations quiet down, and you're treating them with a benign, non-pharmaceutical approach. Immune modulation in heart failure. We present coronary disease as a maladaptive response to both the innate and acquired limbs of the immune system to the presence of vascular wall cholesterol. Crystalline cholesterol is regarded by the innate immune system as a sign of danger. Thus, there's NLRP3 inflammasome activation, generation of inflammatory cytokines, plaque destabilization. We can block that phenomenon with colchicine. Thus, colchicine decreases event rate, risk of heart attack and stroke when added to standard medical therapy in patients with coronary artery disease. Oxidized cholesterol is no longer food. It will not ligate the LDL receptor. Instead, it will be ligated by scavenger receptors of mononuclear cells, and oxidized LDL is regarded as a microbe. Thus, we have an acquired Th1, Th17 skewed, Treg low response to the immune system to perceived infection within the artery wall. Thus, we wish to lower lipids, we wish to lower lipid infiltration and trapping, we wish to blunt lipid oxidation, and then we wish to downregulate this maladaptive acquired immune response with immune modulators such as berberine and pentoxifylline. Likewise, heart failure involves a maladaptive, inappropriate immune response. In heart failure, we have oxidative stress and sympathetic stimulation. Oxidative stress will also skew the immune response away from Th2, away from Treg, and more towards Th1, Th17. Irrespective of the cause of heart failure, abnormal myocardial angiogenic determinants will be expressed by the failing or damaged heart. We do not have tolerance to these angiogenic determinants, and we will mount an immune response against the damaged heart, and we'll begin to reject the heart, further aggravating heart failure. Within hours of a heart attack, we will mount a maladaptive immune response with clones of T cells with receptors specific for these altered angiogenic determinants. So, as we go from a normal individual to somebody with mild heart failure, they have diastolic dysfunction but a normal ejection fraction, to more advanced heart failure with a reduced ejection fraction, the percentage of our T helper cells that are inflammatory, Th17 or Th1, will increase. The percentage that are regulatory, that are going to calm things down, decrease. The ratio of Th17 to Treg cells will rise as we go from normal to diastolic dysfunction to systolic dysfunction. So immune modulators that are of value in atherosclerosis, will they be of value in the treatment of congestive heart failure? So let's talk about pentoxifylline as an immune modulator. 10 to 15 years ago, papers came out describing tumor necrosis factor as a sign and possibly as a mediator of congestive heart failure. And the thinking here was that when you have heart failure, you're going to have fluid retention, you will have bowel wall edema, and then bacterial lipopolysaccharide will translocate across the bowel wall into the circulation, causing immune dysregulation. Indeed, that occurs. We see patients with heart failure and they're plethoric. They actually appear to be infected, and they are, because bacterial lipopolysaccharide is translocating across the bowel wall. And indeed, if we look at TNF-alpha levels in relation to congestive heart failure functional class, as you go from normal people to class 1, 2, 3, 4 heart failure, you see a stepwise increase in circulating levels of TNF-alpha. Likewise, TNF-alpha is a bad prognostic sign because it is a mediator of pump dysfunction. Stated otherwise, TNF as a marker of immune dysregulation is a poor prognostic indicator because immune dysregulation is damaging the heart. The greater your level of TNF, the worse is going to be your outcome. So as the severity of CHF increases, we see greater levels of TNF-alpha. The greater your level of TNF-alpha, the worse is your outcome if you have congestive heart failure. What are the maladaptive cardiovascular effects of excessive elaboration of TNF-alpha? Well, heart failure is associated with cytokine elaboration via upregulation of the nuclear factor kappa beta pathway. So this is TNF-alpha, IL-6, CRP, etc. These are products of nuclear factor kappa beta translocation. Now, the initial thought was this occurred due to bacterial translocation across the bowel wall, and indeed that is the case. But in addition, we get inappropriate nuclear factor kappa beta activation from sympathetic activation, oxidative stress. Oxidative stress all by itself will translocate nuclear factor kappa beta. Oxidative stress leads to inflammatory stress, leads to more oxidative stress, more nuclear factor kappa beta translocation. Our mononuclear cells have binding sites for angiotensin II. Angiotensin II leads to nuclear factor kappa beta translocation. When we have heart failure, we have inflammatory stress, we start making cortisol, we stop making androgens. Androgens will block nuclear factor kappa beta translocation. Androgen deficiency leads to more nuclear factor kappa beta translocation, more inappropriate elaboration of Th1 cytokines such as TNF. So we have this maladaptive immune system activation in heart failure. What are the deleterious effects of overexpressed TNF-alpha? It has a negative inotropic effect. It promotes inappropriate myocyte apoptosis. There's a pathway called FAS-APO1 that is activated, leading to myocardial cell loss that is inappropriate. Matrix metalloproteinase activation, which may degrade the matrix and allow for inappropriate cardiac dilatation. Of course, there's endothelial dysfunction, impaired vasodilatation, and there's a pro-atherosclerotic effect. If the underlying problem is coronary disease, there might be additional ischemic damage. So, if TNF is a bad actor, let's block it. Now, TNF plays a role in autoimmune disease, such as rheumatoid arthritis. And there are drugs available that will wipe out TNF-alpha in the circulation, or you can block its receptor. And these drugs are of value in rheumatoid arthritis. People get better. These drugs are advertised on TV. So if they're so good in rheumatoid arthritis, which is a maladaptive immune response to perceived infection in the periphery due to damage to our joints and immune dysregulation, why not use this in heart failure? So these studies were carried out, and the studies were halted early because not only was the anti-TNF agent ineffective, it actually worsened outcome. So patients that received the TNF receptor antagonists did worse. What's the explanation for this? Well, yeah, upregulated TNF is a bad actor. It causes inappropriate immune activation. But it also has some benefits. When Mother Nature mounts an inflammatory response, she mounts an equal and opposite inflammation recovery response. So TNF-alpha also promotes protection against myocyte cell loss in an inflammatory environment. So with these drugs, we wipe out TNF, we get rid of the bad aspects of TNF, but we also take away the good aspects of TNF, thus myocyte cell loss, more apoptosis, and a worse outcome. Thus, these prescription immune modulators that are effective in rheumatoid arthritis are deleterious in heart failure. And then on the TV ads for these drugs, they always caution you, well, if you have heart failure, talk to your doctor first, because these drugs are deleterious in heart failure. Whenever we really mess with Mother Nature, when we block one of her pathways completely, we get side effects. Now, in the cardiology journals, the editors will say, there's no role for immune modulation in heart failure. What they really are saying, there's no role for prescription drugs that will make big pharma billions of dollars in heart failure. And again, our leadership in cardiology, same as the leadership in any allopathic medical discipline, are primarily academic doctors who are making most of their income doing big pharma research. So they kind of have to defer to their masters and say there's no role for immune modulation in heart failure, and then they're going to ignore a plethora of studies showing that immune downregulation, not ablating an immune response, but downregulating it may be of value. And on my website, I present all these studies on pentoxifylline. I'm going to summarize them at this point. Pentoxifylline works because it downregulates nuclear factor kappa beta translocation. It doesn't wipe it out completely. It just quiets it down when it is maladaptively upregulated. You could almost say that pentoxifylline has an adaptogenic effect. It's going to downregulate a pathway that is inappropriately upregulated, but it's not going to totally knock out a pathway given to us by Mother Nature for a specific purpose. So that's the rationale for immune modulation. We're not ablating, we're modulating. So if we have patients with ischemic cardiomyopathy and we add in pentoxifylline to standard medical therapy, what do we see? Well, C-reactive protein, a marker of a Th1 cytokine, is going to rise with heart failure over 6 months. It's going to drop with pentoxifylline. TNF-alpha is going to drop. Fast APO1, a marker, a mediator of myocyte cell loss, will decrease. BNP, elaborated by the heart in response to stress or strain, a serological measure of heart failure, worsens with placebo therapy, and when we add pentoxifylline to standard medical therapy, it falls. 267 to 46. 100 is the cutoff is normal. That's pretty cool. Ejection fraction will rise in this study. Half of the patients in the pentoxifylline group increased their ejection fraction by above 10 points. Why? The immune system was damaging the heart, too much TNF-alpha, an excessive elaboration of Th1 cytokines. If we block that, if we downregulate that without ablating it, the immune whip is removed and the ejection fraction rises. Again, when we have heart failure, we have a maladaptive neuroendocrine response. The sympathetic nervous system, the adrenals, the kidneys cry foul, and they release hormones to whip the heart into action. Whenever we have heart failure, there's also going to be a maladaptive immune response. If we blunt that with pentoxifylline and related agents, we block that whip, ejection fraction will rise. This type of study has been done in patients with ischemic cardiomyopathy, dilated cardiomyopathy, hypertensive cardiomyopathy, postpartum cardiomyopathy. It doesn't matter what the etiology of the heart failure is, because there's always going to be this maladaptive immune response. And we see a reduction in symptoms, BNP and CRP falls, ejection fraction may rise, and outcome improves. Pentoxifylline as an immune modulator is of universal value in the patient with heart failure. In experimental atherosclerosis, these are LDL receptor double knockout mice. They are a reliable surrogate for human atherosclerosis. They are going to develop atherosclerosis on a high lipid diet, but that is blunted with pentoxifylline. Pentoxifylline in patients with stable angina. Coronary disease is associated with immune modulation. If we treat our patient with pentoxifylline, we see an improvement in treadmill time, time to angina, time to ST segment depression. We're not acutely opening up the artery. We're not acutely regressing atherosclerosis, but we are acutely lowering inflammation and oxidative stress. They didn't measure endothelial function in this study, but if they did, they would have seen that it improved. Thus, we see a rapid improvement in functional status and treadmill performance. If you add pentoxifylline to standard drug therapy, including statins, in patients undergoing stent placement for acute coronary syndrome, what do we see? Well, the farther you get away from the event, there's going to be less inflammation. So CRP will drop at 1 month and 6 months with placebo therapy, it drops a little bit more with pentoxifylline. Interferon gamma falls more. 6-month event rate falls from 34% to 13%. Event-free survival improves. Now, if pentoxifylline was on patent, we would be seeing ads during the Super Bowl. This would be a great wonder drug. But because it's off patent and Big Pharma can't make any money, we're not going to hear about it at all, except that you know about it. So if your patient has an ACS and you add in pentoxifylline to standard drug therapy, including statins and dual antiplatelet therapy, you're going to get an improvement in outcome. Now, if the stent site's restenosis and the patients need a bypass, can we intervene with pentoxifylline? Yes, this study was done. They looked at the effect of pentoxifylline supplementation on patency of coronary artery bypass grafts or peripheral vein grafts, and you can see in red, patency of the grafts was greatly enhanced beginning at 6 months and extending to 24 months when patients were treated with pentoxifylline. Graft failure is due to atherosclerosis. Vein grafts are characterized by insufficient nitric oxide generation. Without nitric oxide, nuclear factor kappa beta is going to translate to the nucleus, making more TNF and other Th1 cytokines. If we blunt that with pentoxifylline, we will enhance graft patency. That would seem to be a good idea. So there's all kinds of studies on pentoxifylline. It's great in so many different conditions because so many of the diseases that plague us are characterized by immune dysregulation. We're shifting from we have too much Th1, too much Th17, not enough Th2, not enough Treg. So virtually all cardiovascular syndromes and all autoimmune conditions are going to benefit from pentoxifylline. It's great in kidney disease. So anything that's good in atherosclerosis is great in kidney disease. Pentoxifylline is of value in kidney disease. So there's a greater discussion on my website. There's a presentation on immune modulation. I present all these studies in greater detail. Famotidine. Famotidine blocks the H2 receptor. Thus, it is used to decrease production of gastric acid, which in a sense is a negative. If you have heartburn and you take these drugs, you'll make less gastric acid, and thus that's going to compromise absorption of nutrients. So we kind of don't like it when our patients are taking H2 blockers or PPIs. However, we can use H2 blockers in the treatment of heart failure, and here's why. 50 patients with symptomatic heart failure, and they had reflux. Their ejection fraction is below 30%. They're on treatment with beta blockers, diuretics, ACE inhibitors, a third are on spironolactone. So standard medical therapy, they're still symptomatic. Baseline study, randomized to receive famotidine, which will block the H2 receptor in the stomach and on the myocardium. The H2 receptor is upregulated in the presence of heart failure. It ties in with the beta receptor and mediates fetal contractility. So in theory, famotidine will have a beneficial effect similar to that of beta blocker therapy in heart failure because both receptor systems are upregulated and they lead to maladaptive fetal contractility. So you treat them with famotidine or a control agent. This was done in Japan. This is a drug called tepranone that has nothing to do with the H2 receptor. So that was a control group, but it might help them with their reflux symptoms. Otherwise, same care, drug therapy is not changed, reevaluated at 6 months, double-blind protocol followed. What do you see? BNP doesn't change significantly with the control group. It drops from 286 to 180. Hospitalization for heart failure over 6 months falls from 24% to 4%. Wow, is that fantastic? So famotidine is another therapy for heart failure, and it costs pennies. It's very, very inexpensive. So if you add pentoxifylline and famotidine to your standard therapies in heart failure, ejection fraction will rise, functional status will improve. This is a good idea and it's very inexpensive. The problem you're going to encounter is getting people to listen to you on this. Colleagues that don't have a background in integrative medicine will say, oh, don't take pentoxifylline. That's an old drug. Switch to the new cilostazol, which is still on patent. And indeed, cilostazol is better than pentoxifylline in peripheral vascular disease, but it doesn't have this effect in heart failure. And if the patient is placed on famotidine, the other doctor will say, oh, you're using that for reflux. Don't take that. Take one of the new PPIs. Well, the PPIs will not have this effect. We're using famotidine not to create hyperchlorhydria. We're using it to block the upregulated myocardial H2 receptor. In fact, PPIs are clearly deleterious. They cause more malabsorption. PPIs actually cause endothelial dysfunction. They appear to upregulate xanthine oxidase. We want to block xanthine oxidase with allopurinol. So PPIs are clearly an enemy. And speaking of hyperchlorhydria, we will create some hyperchlorhydria with famotidine. That is indeed undesirable. Now, we can bypass that with nutritional supplementation, or the patients can simply take a digestive enzyme with hydrochloric acid, and you will rectify the hypochlorhydria created with the famotidine that we're using, not for the gut, but for the heart. Another great therapy in congestive heart failure that people don't want to hear about is unsaturated phosphatidylcholine, particularly 1,2-dilinolenoyl phosphatidylcholine, which will stimulate HDL-associated lesser than cholesterol acyltransferase. Now, this is a fantastic molecule, and if you look at the literature, you'll find 500 papers and abstracts, primarily from Europe, describing the benefit of phosphatidylcholine in the treatment of cardiovascular disease, neurologic disease, and liver disease, but it's off patent, and we don't talk about it here in the United States. But LCAT will take a fatty acid from the second carbon position of phosphatidylcholine, tack it onto cholesterol to create a cholesterol ester, and then we'll load it up and take it back to the liver for catabolism. We can dramatically stimulate this step, which is favorable, with 1,2-dilinolenoyl phosphatidylcholine. The beneficial effects of phosphatidylcholine relates to its fatty acid composition. If we have linoleic acid in the second and third carbon positions, it is far more effective than if we have saturated fatty acids such as arachidonic acid, which will not stimulate reverse cholesterol transport. So you can take soybean or sunflower phosphatidylcholine, distill it, draw off a portion rich in dilinolenic acid, and that will be the medicinal phosphatidylcholine that we will use to treat our patients. Now, this is the schematic of 1,2-dilinolenoyl phosphatidylcholine. It has a branched configuration. Thus, when it is incorporated in the cell membrane, it will promote cell membrane fluidity and elasticity, which is also a plus. So you can distill the soybean or sunflower phosphatidylcholine. In Europe, this is a drug under the trade names of Lipostabile and Essential. And again, I encourage you to look at the literature. It's fantastic, the benefits of essential phospholipid therapy. With essential phospholipid therapy, unsaturated phosphatidylcholine, the enzymes of lipolysis and reverse cholesterol transport are stimulated. Lipoprotein lipase activity will increase. Now, lipoprotein lipase on the endothelium is sort of deleterious. It takes big lipid particles and converts them to small lipid particles that can enter the artery wall. But with respect to prevention of atherosclerosis, we want high levels of lipoprotein lipase in our adipocytes to help break down stored fats. It stimulates less than cholesterol acyltransferase, which mediates reverse cholesterol transport via HDL, and hepatic triglyceride lipase, which also is involved in lipolysis and reverse cholesterol transport. The effects on cholesterol and lipids: cholesterol, LDL, triglycerides fall, HDL will increase, LDL oxidation decreases. Anything that blunts LDL oxidation is going to have a favorable effect in atherosclerosis. Insulin sensitivity improves, so blood sugar falls. There's actually a slight decrease in blood pressure, presumably having to do with cell membrane elasticity and fluidity. Cell membrane fluidity and cell membrane function improves. Arteries become more elastic. It blunts platelet aggregation, it lowers blood viscosity, it has a fibrinolytic activity, microvascular blood flow will improve, it decreases homocysteine, there's an antioxidant effect, and the ratio of peroxycycline to thromboxane improves, so there's a favorable effect on eicosanoid metabolism with essential phospholipid therapy. If we apply essential phospholipids to our patient with coronary disease, we have less angina, less severe angina, fewer nitros are required, you go farther on the treadmill. Claudication improves, walking time improves. If you look at plaque volume with serial ultrasounds in the carotid and femoral distribution, you will see a decrease in plaque size. So there's a direct anti-atherosclerotic effect. This was a study, I believe, of oral phosphatidylcholine looking at the size of carotid and femoral plaques in humans. So these are the larger baseline plaques. These are smaller plaques. You can see there's some expansion of the plaque. These are the larger plaques. They expand and then they regress. The smaller plaques are still expanding and then they become stagnant. This may be because it takes time to turn a ship around, or it might be that there may be phenomena that promote disease regression that at an early stage will expand the size of the plaque. Now, to regress a plaque, macrophages have to be attracted to the plaque and remove the lipid material. So this process of plaque regression may involve low-level plaque expansion first. In any event, plaques are stabilized or they regress, and we also know that this is certainly not deleterious because outcome will improve when we treat our patients with essential phospholipids. Organic pollutants. You're here to learn about how to use chelation therapy to remove heavy metals, and that is indeed very important. And 30 to 40 years ago, chelation therapy was the only means available and the only means required to depoison Americans. Back then, the problem was lead and cadmium. We now have to deal with mercury and other metals that have been introduced to the environment, and now we all have to deal with organic pollutants as another source of inappropriate oxidative stress. Now, these are the chemical structures of many of the commonly encountered organic pollutants. Dioxin, this is the contaminant in Agent Orange, and if any of you are Vietnam veterans, you may have been exposed to this material, 2,3,7,8 tetrachlorodibenzodioxin, and it's still in you generating free radicals. Bisphenol A, PCDDs are polychlorinated dibenzodioxins, polychlorinated dibenzofurans, polychlorinated biphenyls. In any event, whatever we want to call them, they all have a common structure, 2 or 3 rings put together, and this is called the coplanar configuration. So organic materials with this coplanar configuration are going to harm us because, as we'll discuss in a moment, they will tightly ligate the aryl hydrocarbon receptor in an inappropriate fashion. They hijack the aryl hydrocarbon receptor. Now, these are all lipophilic. They travel in your LDL. We take them up from diet and other sources of exposure. They go to the liver, and they're packaged in the LDL, and we will transport them into our plaques. They're persistent to variable degree. That's the problem. Once they're in us, it's very hard to get rid of them, and they're toxic, and we can call them POPs. Persistent organic pollutants, a better term would be PLOPs. Persistent lipophilic organic pollutants. Mechanism of toxicity. Well, what do metals do? Enzyme dysfunction, oxidative stress, cofactor depletion, endothelial dysfunction, receptor ligand interactions. Cadmium binds the estrogen receptor with greater avidity than does estradiol. Thus, there's a link between cadmium and reproductive organ malignancy, and there's genomic predisposition. Some of us have trouble dealing with metals. We are the canaries in the coal mine. How do the organics hurt us? Well, again, here we have endocrine disruption. They tend to be estrogenic and ligate the estrogen receptor. This is one of the reasons that the American male is suffering from hypogonadism. Our testosterone levels are a lot lower now than they were 50 years ago. Baby boys are being gestated in an estrogenic environment because of these organic materials ligating the estrogen receptor. Baby boys are being born with dysfunctional external genitalia. That's not good for the future of our species. Menarche is occurring 3 years earlier now than in 1900, and this was initially felt to be due to, well, better nutrition. Nope, it's just too much estrogen in the environment, and of course this is pathological. Organic pollutants like metals are playing a role in the epidemic nature of reproductive organ malignancy in Western societies. The big problem that we're going to talk about is pathological ligation of the aryl hydrocarbon receptor. Now, the aryl hydrocarbon receptor is totally cool and fascinating. Ligation of the aryl hydrocarbon receptor is involved in our response to the environment and maturation of the immune system, beneficial ligands such as indoles from food, ligands derived from normal beneficial flora will activate the aryl hydrocarbon receptor, and we have an appropriate maturing immune response. That's the way it's supposed to be. But as we'll see, pathological ligation of the aryl hydrocarbon receptor leads to an inappropriate futile detoxification response to these organic pollutants that throws off free radicals pretty much indefinitely. So when we ligate the aryl hydrocarbon receptor, it's going to translocate to the nucleus and start transcribing phase 1 detoxification enzymes. So we have the phase 1 detoxification system that will activate a fat-soluble toxin, rendering it hydrophilic. And then in that process, free radicals are generated. So these are intermediates of toxins that are actually more damaging than the toxin itself, because you're generating a free radical species, so to speak. And then we bind the product of phase 1 detox with a chaperone molecule such as glutathione or taurine or cysteine via phase 2 to then allow the body to excrete it from our physiology. Now, the problem is with pathological ligation of the aryl hydrocarbon receptor, we're going to increase phase 1 activation, and we're going to generate free radicals as we attempt to detox these organic pollutants. But these organic pollutants are not subject to phase 2 detox. So we're kind of in this limbo with an upregulated phase 1 not matched by phase 2. So we're constantly generating free radicals as we futilely attempt to detoxify these molecules. And as our body can't get rid of them, TCDD, if you were exposed to this material in Vietnam, it's still in you, generating free radicals for the rest of your life. We get persistent oxidative stress. Now, let's look at expression of the aryl hydrocarbon receptor in patients with coronary disease. 1,807 Han Chinese, half with coronary disease, half were healthy controls, and the patients with coronary disease were older. They were more likely to be smokers and hypertensive, etc., as you would expect. But let's look at the level of transcription of the aryl hydrocarbon receptor in mononuclear cells. So you're transcribing the aryl hydrocarbon receptor protein at a much greater level in the mononuclear cells of the patient with coronary disease versus the healthy controls. And if we look at, as we go from controls to stable angina to unstable angina to non-ST segment elevation MI to full-fledged Q-wave ST segment elevation MI, we see an increased expression of the aryl hydrocarbon receptor. Pathological ligation of the aryl hydrocarbon receptor with organic pollutants is going to lead to oxidative stress. We carry these organic pollutants in the LDL, and here we have our peripheral mononuclear cells with upregulated expression of the aryl hydrocarbon receptor, so we're going to get a free radical storm. There are genomic variants in the degree to which our aryl hydrocarbon receptor will function. And individuals with a downregulated response, this is associated with relative protection against coronary disease. So if you're homozygous for the downregulated aryl hydrocarbon receptor, now that might have been deleterious a million years ago, but it's of benefit today because you will be less likely to experience oxidative stress in response to organic pollutants. You're the opposite of the canary in the coal mine. So if you're heterozygous, your risk is decreased. If you're homozygous, your risk is further decreased, just telling us that this is a big problem. We don't know what would cause, is the high expression of the aryl hydrocarbon receptor the cause of heart disease, or is the aryl hydrocarbon receptor being expressed at a greater level due to exposure to organic pollutants? Either way, we don't want these organic pollutants. We do not want pathological upregulation of the aryl hydrocarbon receptor. We don't want futile detox attempts with these non-metabolizable organic pollutants because they will cause oxidative stress leading to cardiovascular disease. So we talked about the mechanism of toxicity of the heavy metals, and we have the organic pollutants, primarily pathological ligation of the aryl hydrocarbon receptor, futile detoxification, generating oxidative stress forever. And is there an interaction? Yes, there is. There's this really interesting toxicologist named Harold Zeliger, and I would encourage you to read his papers. He feels that there's a synergy. he points out that these organic pollutants will persist for decades. Dioxin, PCBs, TCDD from Vietnam is there forever. And he also feels that above and beyond the oxidative stress problem, they create rents in the cell membrane and make the cell membrane porous and allow metals in. So organic pollutants will open up the gates for metal toxicity. And if these materials are present forever, we become porous and more sensitive to metals. So some are persistent, others are shorter lived but ubiquitous. We're being exposed to phthalates and aromatic hydrocarbons every day. We drink bottled water. With our IV therapies through plastic tubing, our patients are exposed to phthalates. So we're being exposed to phthalates every day. Some are rapidly cleared but taken daily. Statins and the atypical antipsychotics. We know that statins lead to insulin insensitivity. Some of the drugs used to treat schizophrenia and depression, they lead to weight gain. And his theory is that they're creating rents in the cell membrane, letting in the metals. And he points out that concomitant exposure is not necessary. He's published case reports of people that were exposed to an amount of metal that should not have tipped them over, but because they were exposed to organics earlier, they become more sensitive. And it's quite interesting. So the more toxins we're exposed to, the worse off we are. We all know that the LD10 of lead plus the LD10 of mercury leads to LD100 in animal models. The more metals, the more organic pollutants that we're exposed to, the worse off we are. Again, if we don't clean up our environment and take personal responsibility to remove toxins from our body, we're looking at a children of men scenario 100 years from now. The rates of autism are going to increase. The kids who are not autistic will have other health challenges, allergy, autoimmune disease, diabetes, because our environment is so toxic now, none of us have a fair chance to develop and live a full life. Thus, as individuals, we need to assess our own degree of toxic burden and take aim to resolve this. And as a society, we need to do this as well, or we will not have a future. Organic pollutant epidemiology. I gave a 2-hour presentation on organic pollutants, physiology, epidemiology, and how we can deal with organic pollutants at a ACAM chelation therapy workshop roughly 2 years ago. I believe that presentation was recorded. If not, I will do a voiceover PowerPoint of that presentation and make it available to you. But in any event, organic pollutants are associated with hyperlipidemia, hypertension, obesity, metabolic syndrome, endothelial dysfunction, mitochondrial dysfunction, atherosclerosis, and increased cardiovascular event rate, and they're altering our methyl genome. And this is the really scary part. We can't change our DNA rapidly. We can change our DNA over the millennia. However, we can change the rate at which we read specific genes via methylation and demethylation. If we methylate the start codons on our genes, we will suppress their transcription. If we demethylate, we will increase transcription. Now, this is a mechanism through which Mother Nature allows the developing human to bookmark his or her DNA to help him or her adapt to their environment soon after birth. Consider if your mother was starving or was being exposed to infection, those conditions will be shared by you soon after birth. So Mother Nature wants to prepare you for a hostile or threatening environment early in life. For example, babies gestated in Holland at the tail end of World War II, that's the Dutch famine winter. Now, the Allies liberated Holland, and these babies following birth were adequately nourished. But if you look at them in their 20s and 30s, they are more likely to be diabetes than other individuals, whether they stayed with their birth family in Holland or if they were adopted to the West. This was a situation of nature, not nurture, that being starved during gestation promoted diabetes later in life. What was happening is, because of starvation, there were not enough methyl groups, thus DNA bookmarking, methylation was altered, predisposing you to diabetes because you're going to be thrifty. Because your mother didn't have enough food, you might not have enough food, therefore your metabolic rate will be downregulated, Enzymes that store energy as fat would be upregulated, so you're more likely to become diabetes later in life. Likewise, if your mother was experiencing infection, there's a great deal of oxidative inflammatory stress that will be experienced by you during development, and you will upregulate expression of genes involved in fighting infections. So you're going to be better at making free radicals. You're going to be worse at neutralizing free radicals. That would be adaptive during your first years of life, because the infection that your mother experienced is going to be the infection that you experience. This makes a lot of sense. The problem is that Mother Nature allows us to respond to real threats, starvation and infection. But if we have toxicity in the mother or in the baby with metals and organic pollutants, that leads to impaired methylation. Oxidative stress and infection lead to impaired methylation, recapitulating the uterine environment of malnutrition. So when we are toxic like this, we are programmed to live in an environment characterized by not enough food and too many infections. Thus, we are now programming our children to become diabetes and develop autoimmune disease. And this process is amplified with each successive reproductive cycle. So if a child is born with this impaired DNA methylation, and then they become diabetes and they have lots of inflammation, they conceive another child, the situation is amplified. If you look at the animal models, it's very, very, very depressing. So we are weakening ourselves with each progressive reproductive cycle in this toxic environment. And we have to put a halt to this if our species is going to have a future. And of course, we can deal with this. And it starts with making sure that we, healthcare providers, are healthy. Allopathic medicine is not going to lead us out of this mess. The people in this room are going to lead us out of this mess, because we're the only people that understand this and actually have enough social conscious and drive to get this done. So first of all, we have to be healthy. So I encourage all of you to assess your own toxic burden and begin a personal detox program. Everybody should be taking some form of NRF2 translocator. Everybody should be on an antioxidant program, and we all need to deal with toxicity. You can have your toxic burden measured via many different lab assessments. You can have your metal burden assessed with a provocative challenge. You already understand that, and begin some sort of detox program to upregulate NRF2, to deal with metals, to deal with organic pollutants, because if we're not healthy, we're not going to help anyone else become healthy. So how do we achieve this goal? What is the approach to toxin-induced pathophysiology? I think that 90% of the disease states with which our patients present are due to a lack of knowledge on the patient's part, a lack of personal strength on the patient's part, poor lifestyle, poor diet, etc., and then toxicity. And we have to deal with this toxicity. Stop smoking. Deal with mercury fillings. That was a dumb idea to put mercury into people. If you have iron overload on a genetic basis, and 5% of us do, get blood to lower your ferritin levels. Change your personal environment as best you can. An organic diet and minimize intake of predators. Toxins rise as you go up the food chain. So if you were to follow a vegan diet, you're going to be exposed to far less toxicity than if you are on a Western diet eating meats derived from animals that were raised in factory farms that are loaded with antibiotics and toxins. Evaluate your own levels of oxidative stress. What is your malondialdehyde level, lipid peroxides, 8-hydroxydeoxyguanosine? Deal with that. Look at our antioxidant detox defenses. We can do nutritional testing, looking at individual nutrients. We can look at the signs of not enough antioxidant support, such as low glutathione, elevated lipid peroxides. Do genomic testing. What are your weak links? If you have weak links, don't become depressed. Do something about it. And of course, we can upregulate expression of detox and antioxidant enzymes with NRF2 translocation. What is the treatment? All these toxins are causing oxidative stress. So antioxidant support makes sense to neutralize the maladaptive upregulation of free radical species generation due to toxicity. Optimize our detox defenses. Make sure our kidneys, liver, GI tracts functioning well. Supplements non-specifically upregulate defenses, NRF2 translocators, then active detox. Chelation therapy, which you're learning about in this seminar, specific to the individual metal burden. Organic pollutant clearance is probably just as important. So organic pollutants, how do we deal with this? optimize our innate detox capability, analyze our SNPs, analyze our DNA, and shore up any weak spots, targeted supplementation here, evaluate and neutralize organic pollutant-related oxidative stress, look at markers of oxidative stress, targeted supplementation, antioxidant SNP analysis, minimize ongoing exposure. Now, we can't all go move out into the woods in a log cabin. We have to function in Western society, but do your best to minimize ongoing exposure. Enhance elimination of biotransformable pollutants, increase phase 1, phase 2 detox, promote non-biliary elimination of the unmetabolizable persistent lipophilic organic pollutants. The liver cannot detox many of these organic materials. We have to use other means to get rid of them. That can be a sweat therapy, such as exercise, sauna or far infrared sauna. The flip bath methodology sounds a little hokey, but if you send the water off to a third-party chemist, you will see that organic pollutants are sequestered in the water. You put your feet in a bucket of salt water, you put in electrodes, you ionize the water. Somehow this opens up specific eccrine sweat pores on our hands and feet, and we will detox. And then GI tract pop sequestration utilizing fat-free Pringles. Can we do something about this with diet and lifestyle change? Absolutely. This was the Temple Stay study. They took 25 healthy Koreans, mean age 37, they were not obese, none had taken a prescription antibiotic over the preceding month, so if there are antibiotics in their circulation, it came from food intake. Do a dietary questionnaire baseline study, and then they all moved into a Buddhist temple for 5 days and lived like the Buddhist monks. Vegetarian diet, plenty of water, you repeat the baseline studies. This is just over 5 days. Now, they found that all the subjects had detectable levels of multiple different antibiotics that in their systems that they were getting from the animal protein that they took in, and the antibiotic levels fell in all on a 5-day vegetarian regimen. So we're clobbering our gut flora with these exogenous antibiotics from the animal protein that we take in. You go vegetarian for 5 days, and the antibiotics wash out. All 4 phthalates, there's all these different phthalates that we get from plastics, particularly soft plastics. They were present in everybody. We cannot avoid this, and they all fell on the 5-day vegetarian diet because you're getting a lot of this in animal proteins. Malondialdehyde levels fell in a week. Now, malondialdehyde is a marker of lipid oxidation, LDL oxidation. So in 5 days on this great diet, lipid oxidation attenuates. This would be a very, very good idea. They correlated antibiotic levels with the number of servings of beef, chicken, and dairy products. This is animal products are the source of most of our organic pollutant burden. So we want to minimize meat, dairy, and predatory fish. These toxins biomagnify as you go up in the food chains. If you eat big fish, you're going to get a lot more toxicity than if you eat little fish. If you don't eat animals at all, you're going to experience a lower level of organic pollutant burden. We want to optimize biotransformation. Now, some of these organic pollutants we cannot detox, some we can, so we want to optimize phase 1 and phase 2 detox. We need to look at all the cofactors for phase 1 and phase 2 detox. Basically, all the vitamins and minerals that were in the TAC 1 and TAC 2 multivitamin. All of our patients should be encouraged to take a broad spectrum vitamin mineral program, or we can do nutritional testing and fill in for deficiencies. But nearly all of us are being overtaxed with respect to dealing with toxins. We need a lot more vitamin mineral support than our parents did, than our grandparents did. Particularly phase 2, because if you have phase 1 without phase 2, you're going to generate a reactive oxygen species, but you're not going to get the toxins out. And these are amino acids such as glycine, taurine, glutamine. We need a lot of glutathione. We will use methyl donors here. So we want to optimize phase 1 and phase 2 to clear the toxins that we can biotransform. And we're going to take supplements to upregulate generation of glutathione. We're going to take NRF2 translocators. We can take supplements that will increase the generation of metallothionein and NRF2, so we're better at handling metals and organic pollutants and generating, transcribing antioxidant defense systems, so we can neutralize the free radicals generated by this organic pollutant and metal toxic burden that we're experiencing. So we wish to support phase 1, phase 2 detox to help the liver handle this toxic burden. What about organic pollutants that are not efficiently biometabolized or excreted? Now, in many, biliary excretion is slow, and then they're rapidly reabsorbed. They enter the bile, and 95% are absorbed in the small bowel, so we have a high level of enterohepatic recirculation. So the liver's efforts are all for naught because you're going to reabsorb these toxins. Thus, many of these organic pollutants, they're resistant to biotransformation. They undergo enterohepatic recirculation. They have a half-life of a decade, and while they're there, they're the source of undue oxidative stress. So what if we could put non-absorbable lipophile binders in the GI tract that would bind these organic pollutants and take them out in the stool? And various groups have studied chlorella, cholestyramine. We use cholestyramine to bind lipids to lower systemic levels of lipids. Cholestyramine is also used by some of you to treat fungal toxin exposure and other fat-soluble neurotoxins. You take cholestyramine, these fat-soluble toxins bind to the cholestyramine, they go out in the stool. Rice bran fiber has been used, mineral oil has been used, but the most efficient approach is olestra, which is sucrose polyesters. This is the material used in fat-free Pringles. It feels like fat, it tastes like fat, so if you eat these potato chips with this fake fat, you get the satisfaction of taking a potato chip, but this fat's not absorbed, so it was used in weight loss. Now the problem is that as all this fat goes into your colon, there can be leakage across the rectum, staining your underwear, so this was not really great for sales. So Procter & Gamble is no longer pushing fat-free Pringles, and the public is kind of against fat-free Pringles as a fake food. But it's going to be of value to us to deal with organic pollutants. Now, these materials, particularly olestra, resist pancreatic lipase degradation, maintains an oil-water interface, and it will draw lipophils across the GI mucosa. So if you are biotransforming and excreting these organic pollutants into the small intestine, they're going to all be reabsorbed, except that they bind to the olestra, they go out in the stool. More importantly, some of these lipophiles cannot be biotransformed by the liver. So they're going to stay in our body until they're drawn out via another methodology, such as far infrared sauna or sweating, or if we take olestra. So consider these organic pollutants are in the circulation, as they're in every cell in our body, but they will be in the circulation bound to the LDL. So you've got LDL particles in the microvasculature of the GI tract in close proximity to the lumen of the GI tract. So these molecules want to follow a concentration gradient. So if we have a high concentrate of these organic pollutants in the LDL, they will translocate from the LDL into the gut lumen, bind to the olestra, and then they will be drawn out. So we can detoxify organic pollutants from our LDLs and from the rest of the body in a step-by-step fashion if we take in this material. And it's been used in a number of studies to detoxify humans with non-biotransformable organic pollutants. And in the presentation that I gave, this is one of the premiers of Ukraine, and they tried to kill him by poisoning him with TCDD, and he got very, very sick. This is called chloroacne. This is a sign of organic pollutant toxicity, and they treated him, my understanding is, with fat-free Pringles, and you pull this stuff out. The other way is to pull it out via the foot bath methodology, and we talk about this in more detail in that 2-hour presentation. Methyl cycle nutrigenomics. I give a 6-hour presentation to another group on methyl cycle nutrigenomics. Everybody complains that there's too much science and that I talk too fast. And yes, I do get passionate about this, and I guess I do talk kind of rapidly. Let me just give you an overview of the methyl cycle. So we take in folates from our diet as folate polyglutamates. We convert them into a monoglutamate, and then DHFR dihydrofolate reductase in a two-step fashion will convert folic acid to dihydrofolate and then to tetrahydrofolate. The methyl group used in methylation is derived from serine. Serine will donate a methyl group to THF in a reaction catalyzed by SHMT, serine hydroxy methyl transferase, to form methylene THF. This is B6 dependent. If we're deficient in B6 and serine, the methyl cycle doesn't even get started. And methylene tetrahydrofolate can be utilized to generate purine and pyrimidine bases for DNA and RNA generation and repair, or MTHFR, methyl tetrahydrofolate reductase, which is riboflavin dependent. Without riboflavin, this doesn't work. We make methylfolate. Methylfolate is used to detoxify or convert homocysteine back into methionine. The enzyme involved is MTR, methionine synthase, and it requires the presence of methyl B12, and B12 is methylated by MTRR, methionine synthase reductase. Horrible names, so we'll go by the initials. Anyways, methionine then is converted to SAMe by methionine adenosyltransferase. Many of us bear down regulations here. We have trouble making SAMe. SAMe is the universal methyl donor that donates the methyl group to drive forward 300 methyl-dependent chemical reactions. When SAMe gives up its methyl group, it becomes S-adenosylmethionine, and I will call SAMe SAMe and SAH Sally. And it's the ratio of SAMe to Sally that determines methylation potential. If we have a buildup of Sally, it doesn't matter how much SAMe we have, we will not methylate. Mother Nature doesn't work by absolute values, she works by ratios. So we need a high SAMe to Sally ratio to maintain physiologic methylation. We can have buildups of Sally due to downregulations in the enzyme that converts it to homocysteine. More importantly, whenever we have a buildup of homocysteine, we're going to have a buildup of Sally. We're going to have a low SAMe to Sally ratio, and we're not going to transfer methyl groups appropriately. And this is associated with an increased risk of cardiovascular disease, autoimmune disease, and cancer. Again, we need methyl groups to maintain proper methylation of our DNA. If we cannot maintain proper methylation of our DNA, oncogenes that are supposed to be suppressed activate and we get malignancy. So it's important to lower the homocysteine. Mother Nature gives us several pathways through which we can keep homocysteine under control. We can use methylfolate in the presence of methyl B12 to convert homocysteine back to methionine. BHMT, which is beta-hydroxy methyltransferase, will directly remethylate homocysteine back to methionine. Its cofactor is trimethylglycine. Phosphatidylcholine will help here as well. We can irreversibly catabolize homocysteine to cystathionine and then to cysteine and make glutathione by an enzyme called CBS, cystathionine beta synthase, which, like SHMT, the doorway in, the doorway out, requires serine and B6. When we're experiencing oxidative stress and the body needs cysteine and glutathione, we're going to draw homocysteine down this pathway. There's going to be less available for remethylation to SAMe. So there are people that some of the sickest people in our society have upregulations here on a genetic basis or because they've been dealing with oxidative stress. Their homocysteines are low, but they're really sick because they have low SAMe levels. So we measure homocysteine, but in reality, what we should be measuring is homocysteine, SAMe, and Sally, and making sure that we have an optimal ratio. But whenever you see a high homocysteine in your patient, you know something's off. They're not going to be methylating. This is associated with the increased risk of all these disease states that we do not wish to experience. And while the focus in cardiology has been on homocysteine as a risk factor for atherosclerosis, it's also a risk factor for heart failure. It's a mediator of impaired fatty acid oxidation. If we look at homocysteine levels in relation to the severity of heart failure, New York Heart Association Functional Class 2, 3, 4, we see higher levels of homocysteine. The prevalence of hyperhomocysteinemia rises as we go from 2, 3 to 4. Individuals with advanced heart failure all seem to have hyperhomocysteinemia. This may be due to B vitamin deficiencies. It may be due to oxidative stress. So when we're experiencing oxidative stress for many reasons, including heart failure, homocysteine will be drawn down the CBS pathway. There's less available for remethylation into SAMe. Without SAMe, we cannot burn fatty acids, and Our heart is only burning fatty acids. It doesn't burn sugar. If we have homocysteemia, we cannot burn fatty acids properly, and we cannot generate energy, and our outcome will falter. In one study, they were looking at factors predicting a poor outcome, mortality. Hyperhomocysteemia was a key predictor of mortality. It was a more important predictor than low ejection fraction. Low albumin was another predictor of mortality, I guess as a sign of malnutrition. 3-year survival was 37% versus 73%, and the cutoff was just 14. So if you look at your heart failure patients, many of them will have hyperhomocysteemia. This is a bad sign. We need to correct it. If we have a buildup of SALI, because if you can't metabolize homocysteine, SALI builds up, you have a low SAMI to SALI ratio, that will inhibit catechol-O-methyltransferase. You can't break down catecholamines. Instead, the catecholamines, if you can't methylate them, they'll auto-oxidize and make peroxide and superoxide and hydroxyl. This is a terrible slide, but it talks about how methylation is important if we're going to burn fatty acids. We want to activate PGC1 alpha. That is a master transcription factor. When it's activated, it will lead to transcription of the proteins that are involved in appropriate fatty acid oxidation. So PGC alpha needs to be acetylated, and this is where SERT and NAD plus comes into play. It needs to be methylated. So we need proper methylation. There's an enzyme called protein arginine methyltransferase that takes a methyl group from SAMI and methylates PGC1 alpha to activate it. If this doesn't occur, we don't burn fatty acids. If we can't burn fatty acids, the heart cannot recycle ADP to ATP, and we will have systolic and diastolic dysfunction and a worse outcome. So proper methylation is important, and again, to methylate our DNA. If we cannot maintain proper methylation of our DNA, oncogenes that have been suppressed will activate. So as we age, we experience oxidative stress, we run low in our methyl groups, we can no longer suppress oncogenes, we get more malignancy. Many other enzyme systems are dependent upon a proper SAMI to SALI ratio. Thus, homocysteine control is important. Proper functioning of the methyl cycle is important. Now, in allopathic medicine, homocysteine is ignored because A, there are no drugs that will promote the metabolism of homocysteine. Of course, only Mother Nature can metabolize homocysteine. In some of these early studies, they would use low doses of one or just a few methyl donors, and homocysteine would fall a little bit, but outcome was not improved because you need to pay attention to the entire methyl cycle. Some of us just need methylfolate, some need B6, some need B12, some of us need serine. You have to evaluate our nutritional status. We have to look at our DNA. Some of us are going to need much more methylfolate support than others. Some of us need more B6 than others. So we have to analyze our entire biochemistry and fix it. And if we do, we're going to have proper methylation and protection against many disease states. This completes part 4 of the web-based version of Integrative Cardiology for the chelating physician. Part 5 discusses non-drug approaches to cholesterol control and begins with a phrase I hear all the time: "Doctor, I just can't take a statin."